So a round of applause as you welcome him. Welcome, Professor Mbesai.
Good morning. I hope you can hear me. There are two mics. I don't know which one works best. So you heard from the short, I'm with you about climate change and health. So then the question comes, why should we talk about climate change? As we know that climate change has a lot of schools of thinking. There are many people who don't believe that it's real. So there are some people who think that it's not happening, or just you could hear in the upcoming US elections. But climate change is real, and it's one of the biggest health threats of 21st century. As health professionals and the researchers, we are supposed to look at the effect of climate on health. So from the projection there, we could see that the change is happening very slowly. So it's not like a weather event. Today it is raining, tomorrow it is cloudy. So this, what we are talking is about what has happened over the past 150 years. And it is mainly contributed by greenhouse gas emission, which cause temperature, precipitation, and the humidity to change, and they affect our living organisms, including humans, because we are also part of the living organisms. So the main causes are fossil fuels and the use of land, mainly for agriculture and forest. Those are main contributors to climate change. So what is mainly happening, you could see that the greenhouse effect we immediately face, because we are all living on the Earth's surface. So you see that the sun, which is very far away, it is shining on the Earth's surface, and the radiating infrareds, which they land on the Earth's surface, and some are reflected back. So the greenhouse effect, those gases which are on the surface, they absorb some of these infrared radiations and they send them back to the Earth's surface. So could you see some infrared radiation coming down to the Earth? So when it comes to basics of climate science, there are a number of gases, including ozone, methane, and the water vapor, which is coming from the water bodies. And I wonder why this slide you could not stand properly as it was supposed. So there are a number of gases, including a number of hydrocarbons, which constitute greenhouse gases. So if you want to read more, it depends on your specialty. If you are environmental scientist, you can go and read more on that. But it is true that there's strong evidence which show that greenhouse gas emissions are warming the globe, and they are leading to accelerated pace of change. So this is very evident in the past 10 years. So in the slide above, you could see those are the effects which have been recorded in different parts of the world. You could see clearly that Africa is contributing less to the global warming. But in Africa, Tanzania is also among the 15 countries which are contributing to global gas emission. Tanzania is just down in the figure number C. You could see Tanzania is down here, and Uganda. Partly maybe we are driving Second-hand cars, we are using a lot of diesel cars. And also we are warming our rooms with air conditions. So we create a lot of heat to the environment. So this is a very clear figure that Africa is contributing less compared to Asia and Northern America and Europe. But people face the effect of climate change, especially on health, in low and the middle income countries, and we are falling under that category. So women, children, and the people in poverty are the ones who are facing the consequences of these emissions. So even within the countries, the poor people, they face more consequences of global gas emissions. So here's an example of temperature records in Japan. You could see from the early 19th century to 21st century, there's a very clear trend of rising temperature over time. So maybe the meteorological station in Japan, they're keeping very good record of their temperatures over time. So we'll see later what is happening with Tanzania. So then the key issue, what is the global impact of climate when it is changing on our health? We see rising temperature and the health risk, extreme weather events, as we will see later, air pollutions, spread of infectious food diseases, and also food and waterborne diseases are spreading more. So in recent years, even this year, we've seen that there's flooding, landslide everywhere in Tanzania. Even now it can be raining, although it is not the time to rain. So these are some of the potential impact which you could have. And they somehow affect our health. So for you, I saw some of our presentation yesterday. Most of them, they are confined in the clinical setup, but we are all in the environment. We face changes in temperature, sea level, precipitation, and the humidity, and then it results in a number of changes in the heat, changing the vector of biology, air pollutants, food supply, civil conflict, storms, and the flooding. All this will increase number of admission in our ward. Then we'll be reporting number of patients coming with sepsis at Muhimbili National Hospital. But those patients, they are coming from our environment, and they are exposed to all these adverse consequences. So what have we to do? Because what I'm talking, maybe it is very common even in the popular media, we have this information. Then what more can we do? I think this slide is also somehow invented for known reasons. But the point of discussion today is that this effect of climate change, they are not the same everywhere. So their pattern of presentation are different from different parts of the world. As we have said that there may be happening more in low and the middle income countries, but also it is the one documenting. Because we don't record and we don't keep data, we just work on the data today, and then after 2 days, we don't keep records. So a lot of effects are recorded somewhere else, but maybe they are more in our setup and we are not reporting them. So while I was preparing this presentation, you could see that this is coming from news channels. You see several countries are experiencing extreme weather events. There is Hajj pilgrims who passed away because of heat stroke. So these are normal news which you can, once you switch on your TV, you can get similar news like this one. In Tanzania, you can hear about in Yangwan, landslide in Hanang. Those are some of events which can be attributed to climate change. So when it comes to documenting, the WHO to documenting on the effect of climate change, effect of heat-related death in America, but these are very conservative figures which show that the effect of climate change. So more mortality is happening because people are dying from higher temperatures, and mainly in urban centers. So these are documentation which are mainly coming from Asia, America, and Europe, but we'll see what is happening in sub-Saharan Africa. So as I've said before, in sub-Saharan Africa, we may be much more vulnerable to effect of climate change, but we may be lacking key statistics on vector-borne diseases, including malaria, tick-borne infections, or rodent-borne infections, food insecurity because of limited documentation, and also socioeconomic status. So this is also coming from WHO record. It is clearly showing that with increasing temperature, there may be loss of diversity, biodiversity, morbidity, and the mortality will increase due to infectious diseases, and they reduce the food security over time. So these are figures which have been made mainly from mathematical modeling, but we need really data which should come from our setup or in our local setting. One of the important areas which you could see, like WHO, they've given some conservative data on malaria transmission, and we know that malaria transmission, for it to happen, you have a parasite and a mosquito and a human body, but in between you have environments. You need temperature, you need rainfall and appropriate humidity to support development of the mosquito, of the plasmodium inside the mosquito, and also development of the parasite in the human body, so that the transmission can happen. So that is part of the malaria cycle. So there's a documentation from research that we expect that there will be more cases of malaria. Before I started presenting, someone was asking, is malaria going down or up? I said, it's very difficult to say because there are environmental issues which are beyond our control. So here we are looking, how can we link between climate change and the malaria? But it's not only that. There are also arboviral infections, which are more prevalent, and also we are expecting to have more tick-borne fevers as a result of changing climate. So also this figure somehow is disrupted in the way it is projected. But this it is coming from modeling of data from GPA, malaria, temperature, and the other data, which shows that in 2030 to 2050, we are expecting to have more cases of malaria as a result of global warming. So there are a number of variables which were put in the mathematical model to come up with these figures. Then when it comes to non-infectious diseases, before I came up with this presentation, there was also another webinar and a paper which recently came from Frontiers in Science, which also provides more evidence that climate change is driving an increase in immune-mediated diseases. So what is mainly happening that the effect of climate change are somehow affecting or dysregulates our immunity, and increases frequency and the severity of various types of diseases. For example, the allergies, autoimmune diseases, and the cancers are expected to increase as a result of climate change. So this article is new and it is published maybe this month in Frontiers in Science. So the effects are not only to communicable diseases, but also to non-communicable diseases. So when we see these changes happening, or we see more cases of cancer or autoimmune diseases or allergies, we should see how best can we link or do research and link them to climatic events. So what's about Tanzania when it comes to climate change? If you look on the WHO page on statistics on climate change, there's very limited data reported on Tanzania. I think there are two studies or one talking about heat on Dar es Salaam, and they also change in rainfall pattern, which increases drought and the water scarcity in the communities. So those are some of the studies which were reported in Dar es Salaam. And we are expecting for Tanzania maybe because of climate change to have increased malaria transmission and the waterborne diseases. We can call them water and the foodborne diseases as cholera and the diarrhea. And recently we had a lot of flooding in Rufiji. So we expect maybe increase of waterborne and foodborne diseases. Heat-related illness were reported in Dar es Salaam. So we may need more data from researchers from this area. Indirect effect could be as a result of and the displacement people could have. So these are some pictures from parts of Tanzania where there's droughts and it's difficult to obtain water, which were somehow shared in the WHO page. So we need more from you to work on case studies which are related to climate change. So this is part of East Africa. So recent Idaya storm which happened in Kenya, parts of Mafia, Dar es Salaam, so could you see those are the effects which happened in the part of East Africa. So the major issue is to discuss how can we help as health professionals to address the effect of climate change. I know a number of studies which have presented, all of you have heard in one way or another, but how can you contribute as health professionals to talk about climate change and they also engage in mitigation and adaptation strategies? So could you see from the international stage, there are a number of conventions, sustainable development goals, and even in Tanzania, we have somehow adapted some of the international agreements contain effects of climate change. So the key issue here is to ask you, how much do you know about these Tanzania documents on climate change? I'm afraid my slide was not very clear, but there's a Tanzania developmental vision, which is also addressing on issues of climate change. There's also a document from Zanzibar talking about climate change. So these are the issues which, as Tanzanians, we need to engage when we are talking about health. So to address the impact of climate change, there are three grand challenges, and I'm happy that MUHAS now is the innovation hub. So they should also include innovations which can promote actions that reduce carbon emissions and improve health. If our students in bioengineering, they can come up with innovations which can reduce carbon emission and improve health. Maybe if you can have different designs of how best way of addressing these issues is welcome as part of innovation. We need to build a more resilient and environmentally sustainable health system. So here we are talking about strengthening core function of the health system. So it is good that you are here. So which areas of the health system should we be looking at which can be part in addressing the issues of climate change? And also we need to implement public health measures to protect from a range of climate risk to health. So here it calls on developing policies which can address the effect of climate change. So there is a call of action on leadership and advocacy for climate resilient health system. So every time we are designing anything, we should be considering on the effect of climate change. That could be part of the activities of health professionals and the research institutions. We also need to have continued research and the policy development. Here we need to provide evidence and the monitoring. As you have seen before, on our page on the effect of climate change, there's very few reports which are coming from Tanzania and the other developing countries. So we need to develop more case studies, document more what is happening in our clinical settings. We should not see patient data from the clinical room alone. We should take it global and monitor trend of different diseases over time and see whether we can link them to the effects of climate change. We should also clearly teach our patients and the community members to understand what is climate change and what are the potential effects of climate change and how can they contribute in the implementation of mitigation measures, which we later on see how they will help to improve better health. So here is what can be mainly done by higher learning institutions and the research institutions to contribute in mitigation and the adaptation on the effect of climate change. One thing which you might need is to have competence in data science methods. So here it's when you need artificial intelligence, you need mathematical modelers, you need the other scientists to come together to work on different data sets which may be available at our country and also at the international level. For example, if we take an example of malaria, we have data which is emerging from Tanzania Meteorological Agency, but also we have data which is coming from satellite data, which is freely available from NASA and the other institutions. We have Malaria Atlas Project, and we need to add maybe more data on mosquito ecology, and then model those data to our local setup and see how can we address the effects of transmission of vector-borne diseases and link them to climate data, which is mainly temperature, humidity, and the precipitation. So that's where we need. And the good thing in this room, we have young students. So this is your time to learn more, maybe in your postgraduate learning, to study more data science. When it comes to modeling, this is a new field to everyone. That is a good thing. So there are very few universities in the world which have very good modulars. So here you need, so this is time for you now to spend more time to learn about data science method and how can you link it with artificial intelligence in addressing some of the sustainable development goals. And for biologists, we need also to search for novel biomarkers like which can be used to study effect of climate change and linking it to environmental exposure and the disease etiology. So it's not something simple which you can collect in the world, but you need also to work in the lab. For economic scientists, we need also to standardize our modeling method so that we can add the variables of economy in the modeling the effect of climate change, how are they affecting our health and also equity. We know that here it is women and the children who are suffering more when the effect of climate change. So here there's opportunity, and every time there are calls, whether you like them or not, but those are things which are happening. So there are calls from, even recently there was a call from COSTECH on climate change, on health, agriculture, and the other sectors. So as a health scientist, what will you do there? There is call from Bill and Melinda Gates on the same areas. If you go to West Africa, they're a very strong team of modelers. So young people, instead of wasting time chatting, they are working on big data set on how best to link climate change with the other variables, transmission of disease, on economy, on social factors. So this is what we are trying to do. MUHAS, collaborating with the other institution in Tanzania, like the Tanzania Meteorological Agency. Thank you. We are working together to try to model the kind of data which is available at Tanzania Meteorological Authority and the malaria over time. So we've teamed up and we submitted an application which passed the first round. So we are waiting for the second round. If successful, then we'll have some activity on that area. So here you could see that TMWay is rich of data on climate. They have data from 1960s, but that data is in hard copies, maybe half of it. So we need money to digitalize that data and then make use to link it with different disease conditions. For example, with malaria, we can use it for other bacterial infection, arboviral infection. You can also use that data. So you could see, if you need to understand more, you can visit TMWay and they will be very happy to collaborate with you on different aspects of health or climate-related effects. So they need us and we also need them. So make sure that everywhere they've seen address that we need some information on climate. So, and also they have good modulars. And I'm sure at MUHAS will soon also have modulars. So this is a cycle which shows how best, if we focus more on mitigating the effect of climate change, we can come up with a climate resilient development. So there are issues which are affecting our health, like the ecosystem and the biodiversity is reduced. But if you address those issues, will improve health. And then improve health, also improve outcome, and they will be living in a better world. So if you have time, you can study those halos and see how they might contribute to the quality ecosystem and reduce the effect of climate change. And how can it be done? As I've said, we need to document effect of climate change, we need to design innovative ideas or innovations which can be used to intervene the effect of climate change. And later on, we need to evaluate the effect of those innovations. By doing so, as health professionals, we'll be addressing some of this effect of climate change. So I think that's where we can have much more contribution on the effect of climate change. And also we need to learn, because as I've said, we have few modelers, and maybe we are not very good in mathematics, but you can also learn how to work with big data sets. And you cannot work alone. You need to collaborate with a number of institutions. So when we are submitting this application, you usually work with so many institutions. Sometimes it's even difficult to manage them. But we need to learn to do that. So there are some issues which as health professional will be contributing. There are some issues where mathematician will be contributing, and the computer scientist will be contributing. So we have different people from local institutions and also from the northern collaborators. So this is an area which you cannot avoid at any moment. Every time we'll be hearing about public health meetings or international conference where the issues of climate change are addressed. And us as health professionals, we cannot avoid it. So we will be supposed to go outside of our wards and look what is happening in our environment. How can we use a lot of data which is coming from the satellite, from the meteorological agents in Tanzania and the neighboring countries? And we don't have a strong hub in East Africa. So this is an opportunity if you engage in any research activity where they are talking about the issue of climate change, and you can be one of the partners. So in conclusion, I could say that climate change is real, and the most it is human induced. As we said before, the contributors to it are forced related to agriculture and the forest, and we are all dreaming of driving, taking flight here and there, or traveling everywhere. So we are contributing to that. There are negative effects of climate change, but also there are opportunities for renewable resources of energy and also for innovations which can improve health. So we need to start taking action and to act now as a community. So we should make sure anytime we think of public health, and then this conference soon coming on public health, discussing about climate change and One Health. So we know there are a lot of disasters when the climate is changing. So in short, that's what I aimed to talk to you, to make you engage in different activities related to climate. So we should not be afraid of working with big data sets. Thank you for listening.
Thank you very much, Professor Bill Gasala, for enlightening us on climate change and health. I think you will agree with me that he's a professor in malaria, but he has linked us very well on climate change, as if he has been, he's a professor in climate change and health. Thank you very much. Makofi hayatoshi, makofi tena kwake. Professor Bill Ngasala liked questions, so he wanted to be asked questions. Then I told him, as per our protocol in keynote speech, when you finish, you just go and sit, then they will assimilate. if they have questions, they will just follow you outside. So thank you very much. We are lagging a little bit behind. Now to parallel sessions. And we will be having maternal new non-communicable diseases, mental health, surgery, and nutrition. Will be sitting at the Benjamin Mkapa Hall, which is on the second floor, right wing, the site, for those who are joining us today. And the non-communicable disease and antimicrobial resistance will be sitting at the Jakaya Kikwete Hall, which is on the fourth floor, left wing, fourth floor left. And the fourth parallel session is on social determinants for health and cost-cutting issues. We'll be sitting at the John Magufuli Hall, which is on the third floor, right wing. So having said so, I wish to thank you all for joining this keynote presentation, and I kindly request that we move to respective sessions as I have given the geography. And I wish you to request the chair for this session to come and take over, because my employment has officially expired in this venue. So thank you very much.
Good morning. Good morning, everybody. Can I kindly request everybody to get seated? And we are about to start our parallel session. We have an interesting parallel session that is looking at for not going to be with us today, and I will be taking his place. So I think without further ado, each of the presenter will be given, is it 7 minutes? 7 minutes for the talk. And Arnold, can you get somebody to show us the time? Yeah. So when we have 3 minutes remaining and 1 minute remaining. Yes. So I think I would like to welcome the first presenter. And our first presenter is Dr. Asma Zain Ali. She's an obstetrician and she'll be talking to us about the factors influencing pregnant women's knowledge, perception, and attitude towards premarital sickle cell screening. So I think this is an interesting area, looking at the premarital screening. Karibu Asma.
So, good morning. I'm Dr. Asma Zain. Was done through SPSS 23 with independent variables were analyzed in terms of frequency and percentage, and factors associated were analyzed using logistic regression with p-value of less than 0.05 significant. So these are the results for the socio-demographic factors, and it shows that amongst the people who attend, the women attended, less than half, around 48%, were between age of 26 and 35. 43.5% had a college level of education, with 39.3% women were married, and more than 1/3 participants were self-employed. So this is what, as I discussed, the mean age of the participants was 29, and less than half was between 26 and 35. 43.5% had college level of education, 39.3% were married, and more than 1/2, that is 36.5% of the study participants were self-employed. Other data that I concluded was 2/3, around 70.8%, were in the 3rd trimester of pregnancy, and 42.3% had more than 2 pregnancies, and 71.5% had no history of abortion. So according to the results, for the knowledge on premarital screening for sickle cell disease, the adequate knowledge percentage was only 6.5%. For positive attitude, it was 68%. For perception, for positive perception, we had 68.75. So as you see, the knowledge regarding premarital screening on sickle cell disease, it was poor, it was inadequate. Around 93% did not have adequate knowledge. So as we move on, the questionnaire that I had, I just want to highlight. So majority of people, around 64.3%, knew that sickle cell disease is diagnosed by a blood test. 58.8% knew that carrier of a sickle cell gene passed the gene to a child. And 65.3% agreed that it should be done before marriage. Premarital screen should be done before marriage. For the attitude, which showed around 68% positive attitude, out of which 66.8% showed it is good for everyone to know his genotype, like if he's a carrier or not. And 48% knew that there's an importance of premarital screening before marriage. For perception, 57.5% agree that it is an important step for reducing the burden of sickle cell disease. And 64% agree that it is important. The awareness for premarital cell screening is important for community to reduce the burden of sickle cell disease. So for finding the associate factors, I did univariable or multivariable analysis. So by adjusting the confounders, I got for attitude for premarital cell screening. Premarital screening, only education seemed significant, which showed people with secondary and college education had 2 to 3 times more, 2 to 3 times more, here. So education, the woman with college and secondary education had more positive perception, attitude towards premarital screening. When we moved for perception, it showed those who were employed had two times more positive perception for sickle cell disease. So the results are the study revealed that age, marital status, level of education, gestational age, occupation, gravidity, and parity were not significant factors that influence the level of knowledge. So there were no associated factors along with knowledge. And with higher levels of education are more likely to have positive attitude towards premarital, and those who were employed had positive perception. In conclusion, this is I've discussed already. The majority had inadequate knowledge for the genetic risk and benefits of premarital screening. 68% had positive attitudes and 68.75% had positive perception. And this study revealed that employment status is associated with positive perception, and however, education is associated with positive attitude. So recommendations to develop educational programs to fill the knowledge gaps for premarital screening for sickle cell disease, collaborate with community leaders, health officials, religious leaders, and government organizations to ensure the information reaches a wider audience, and to encourage screening for sickle cell disease and counseling services before marriage. This marks the end of my presentation. Thank you very much.
Thank you, Dr. Asma. I will please keep your questions. We'll give time for questions at the end. So the next presenter is Dr. Amne Suleiman. She's also an obstetrician, and she'll be obstetrician gynecologist. She'll be talking about short interpregnancy interval, its associated factors and related pregnancy outcomes among patients at Mnazi Mmoja Hospital. Karibu, daktari. Thank you. This one.
Good morning, everyone. So my name is, as introduced, is Amne Suleiman. I'll be here presenting short interpregnancy interval, its associated factors and related pregnancy outcomes among admitted patients at Mnazi Mmoja Hospital. This study was under the supervision of Professor Projestin Muganyizi and Dr. Ali Saidi. So to begin with, interpregnancy interval is defined as the time a woman is not pregnant from the end of the previous pregnancy to the beginning of the subsequent pregnancy. And as per WHO, it is recommended the interpregnancy interval to be not less than 24 months if it is from a pregnancy outcome of birth, and not less than 6 months if it is the pregnancy outcome of abortion. So several studies have been done that have shown that short IPI, short interpregnancy interval, has adverse pregnancy outcomes for both fetal and maternal. And there's variation of prevalences across the globe, more than 1/3 in the USA and China, almost more than 50 in African countries, as well as local studies that have been done in Tanzania. IPI is a modifiable risk factor for the outcome of these maternal and fetal morbidities and mortalities. And it is estimated that 20 to 35% of maternal death can be prevented by adhering to the recommended IPI. So the objectives, the broad as can be seen, the specifics to determine the prevalence of the short IPI, to determine the factors associated, the fetal as well as the maternal outcomes. So this was a hospital-based analytical cross-sectional study done between October and December 2023 at a tertiary hospital in Zanzibar, which is Mnazi Mmoja Hospital, among 424 admitted women at the hospital. So a structured questionnaire was used to collect data from the participants that were enrolled. And the data collected was from the study participants, the RCH card, the pathograph, and the patient's file, and the data analysis, as can be seen from the slide. So moving on to the social demographics distribution, as we can see, majority of the participants were between 25 to 29 and 30 to 34, and mostly residing in urban. The median age was 30 with the interquartile range of 26 to 34. Almost all of them were married and living with partner and Muslim. More than 3/4 had secondary and above level of education, but majority were unemployed. On the obstetric characteristics, majority were multipara and only 3.1% attended antenatal visits, contacts as per WHO recommendations, which is above 8, equal or above 8. And 1 in every 5 women had an unplanned pregnancy. To the family planning use, almost 20% were not using any method of contraception. And for those that were using, majority were using natural methods. This is just to show the IPI distribution, which is 35.6% had short IPI. On the distribution of social demographics with IPI, only age group in years, a higher proportion of short IPI was found in the participants aged 25 to 29 and 30 to 34. And this was the only variable significant in the social demographics. And family planning was the only variable in the obstetric characteristics. In the bivariable and multivariable age groups, it was shown that it was almost twice the odds of having short IPI in the age groups of 25, 29, and 30 to 34, and more than twice in the family planning, lack of family planning use. So in the adverse fetal outcome, it was shown that a significant difference in proportion between the short and normal were seen in the stillbirth, as can be seen in the stillbirth being 16.6% in the short IPI and 7.7% in the normal IPI, and as well as for the birth weight, the prematurity, and admission to neonatal ICU. In the maternal outcomes, anemia and preterm labor had a significant difference between the short and the normal. However, in the hypertension, it was more in the normal IPI than in the short. This is just to show the odds ratio of the fetal and maternal outcome, in which stillbirth was more than twice, low birth weight more than 4 times, prematurity 5 times, and neonatal admission 2 times, with anemia almost twice, preterm labor 5, and hypertension actually protective. So in conclusion, as I've said, more than 1/3 of the women admitted at Mnazi Mmoja Hospital had short IPI, and age and lack of family planning use were identified as significant factors. And it was shown short IPI was associated with increased adverse pregnancy outcomes. So in the recommendations, it is provision of education not only to the postpartum women, but also to the women of reproductive age. And as I said before, short interpregnancy interval is a modifiable risk factor. So the key point is to control family planning. And as we have seen from the study, majority of the family planning users relied on natural methods, which are known to be least effective. And of course, further studies are needed not to assess the factors that hinder the access, the provision, and the use of the contraception. Thank you.
Asante, thank you, Daktari. And so I think we are still in the area of obstetrics, and so the next and gynecology. The next presenter is Dr. Anna Kasilika, who is a reproductive physician, and she'll be talking to us about the pattern of infertility risks and treatment for patients at Benjamin M. Mkapa Hospital. And this is an analytical processional study. You're talking. So I think we will be having other two presentations after Dr. Anna, and they are all obstetrics except one which is looking at the neonatal resuscitation. So I believe we'll have a good discussion afterwards. We're just getting the presentation from the this presenter because it was not loaded here. We apologize for that. I'm wondering if it will be okay to switch Dr. Anna's presentation with the next presentation. Do we have Demetria Matanda with us? Yes, and that is Dr. Demetria. So can I ask her to give the talk while we are waiting for the presentation from Dr. Kasilika? Dr. Demetria will be giving us a talk on cesarean section in Temeke municipality, proportion, indications in maternal and fetal outcomes at an upgraded health centers. Karibu, Daktari. I think this is your talk. Sindoye. Yes.
Good morning, ladies and gentlemen. I'm Demetria Matanda. I'm here to present my dissertation with the title of Proportion of Cesarean Section Indication Maternal and Fetal Outcome Among Women Delivered at Upgraded Health Center in Temeke Municipality. My supervisor was Dr. Ali Said, together with Dr. Lilian Mnabwiru. So going into background, the cesarean section is a surgical procedure that can save lives, but its access varies significantly between the geographical location, leading to disparities in maternal outcome. Tanzania has been upgrading some of its health centers to provide comprehensive emergency obstetric and neonatal care services in order to improve access and quality of maternal health care, including cesarean section. The upgrading was based on allocating the training staffs, also renovating the theater rooms, and buying the equipment and supplies which are necessary for emergency provision of the emergency obstetric care and neonatal care. So the study aimed to determine the proportion, indication, outcome, and of cesarean section among women delivered at upgraded health centers. The objective of the study was to assess the proportion, indication, and the outcome. This one of the broad, the specific objective was to look on proportion, to look on to determine the indications of cesarean section, again to determine the cesarean section outcome concerning the maternal and fetal outcome. Those was the specific objectives. The methods, it was a descriptive cross-section health-based study, which was comprises 452 women who delivered at upgraded health center in Temeke municipality from January 2021 to December 2022. And the study area, the health centers which were included, it was Majimatitu Health Center, Mbagala Round Table, and Yombo Vituka Health Center. So all of them, they are providing CMOC service at the study period. The study population were included all women who delivered at those health centers. And the selection of the files was by random sampling, and the checklist was used to obtain the informations, and the statistical package for social science was used for data analysis. The results, the proportion of cesarean section at upgraded health center was 21%. The mean age of pregnant women was 26 years, with 92% were between 18 and 35 years. Women who delivered by cesarean section, it was 25% in Majimatitu and 20.5% in Yombo Vituka and 17.3% in Mbagala Round Table. Among these, elective cesarean section were 20.9% and 79.1 were emergency cesarean section. And fetal distress were the leading indication. And on looking to Robson group, the Robson group 1, the lower risk group, were the major contributing of the cesarean section proportion. These are the table showing the cesarean section, and the fetal distress were the leading, followed by previous cesarean section. The distribution of cesarean section according to Robinson criteria, as I said, the nulliparous single cephalic were the leading group. And looking on the demographic data, majority were age group of 15 to 24 and 25 to 35. More than half were para 1 to 3, and around 3/4 made 4 to 8 antenatal visit. And fetal outcome, majority were singleton. Almost 100% have live births and scored more than 8 at 5th minute. And only 5% of those babies, they had neonatal ICU admission. And on maternal outcome, we had several maternal outcome, wound dehiscence and all maybe like surgical site infections, but all of them, they are not found, but we only found that majority, they have a good outcome with the hospital stay of 3 days, and then they discharge with good health. So in conclusion, there is a high proportion of cesarean section at upgraded center in Temeke municipality. The fetal distress, history of scar, and the cephalopelvic dislocation were the leading indication of cesarean section. Nulliparous women in spontaneous labor were contributors. Generally were good immediate maternal and fetal outcome. So on recommendation, we recommend following high cesarean section, we need to have further study to look on association factor contributing the high cesarean section in upgraded health center. Thank you very much for listening.
Asante, Dr. Demetria. Thank you so much for your talk.
Okay. Okay. So, good morning. Sorry for the inconveniences. My name is Anna Kasililika, and it's such an honor and privilege to speak with you. The results of a study titled Pattern of Infertility, Associated Risk Factor and Pre-Existing Fertility Treatment Among Patients, Attended Assisted Reproductive Clinic at Benjamin Mkapa Analytical Cross-Section Study. So this study, I collaborated together with Hindu Ibrahim, Dr. Henry Stefan, Dr. Alphonse Chardika, and Dr. Cecile Kwesheni. So this is the outline that I'll follow, starting from the introduction to the reference. So what is infertility? Infertility is the inability to conceive after 12 months or more of a regular and protective sexual intercourse. It's a global health problem, affects 1 over 6 people in the worldwide, and it affects the quality of life, and that is in terms of the verbal abuse, social stigma, sexual dysfunction, divorce, risk of multiple partners, and risk of STDIs, that including HIV. So with infertility, they can be primary or secondary. And when we say primary, means this couple have never had children in their lifetime, while secondary is that they have, but currently they are facing a trouble. So we had a question about the pattern of infertility among the patient, because varying studies have reported a varying pattern of infertility. Some, they say that primary infertility is more common than the secondary, while the others saying secondary is more common. So we went further to understand what is the risk factors for infertility. And because different studies have reported controversial risk factors for female and male. So we also want to understand what kind of fertility treatment our patient gets, because normally we understand fertility treatment is normally initiated after 12 months, and sometimes less depending on the medical condition of a patient. And the fertility treatment can be medical or surgical or assisted reproductive treatment. And assisted reproductive treatment is the one which is recommended, and it has helped people, but there are limited information regarding all these treatment. So we had an objective that to determine what is the pattern, what is the associated risk factor, and what are the fertility treatment among the patients who attended Benjamin Mkapa. So it was a hospital-based analytical cross-section study involved 385 female and male patients with infertility. And it was done at Benjamin Kappa. We had ethical approval from University of Dodoma. And we used our clinical performer to help us in data collection. And we use frequency, percentage, crude oil ratio, and adjusted ratio to help us during analysis. So what we found, the age of, the mean age of our patient was 34 years. Most of them were married, university degree, overweight, urban. They were central zone, and they were involved in teaching institute. So regarding the pattern, we found that secondary infertility is common, and that is affecting like 59%. And the risk factor that were significant in this study were age, more than 35 years, duration of cohabiting or marriage, more than 10 years, frequency of sexual intercourse less than 3 times in a week, and cesarean section. We also found that on the fertility treatment, majority of women, they use herbal medication, and that is about 58%. And for men, they hardly get any medical or surgical treatment. And for assisted reproduction, very few had undergone assisted reproduction, like 4.3%. So in summary, we can say that we found that dominant pattern is infertility, was secondary infertility, with risk factor the age, frequency of less than 3 times in the week, and duration of cohabiting or marriage less than 10, and the previous cesarean section. And male infertility is inadequate managed, herbal medication is widely used, and access to ART services is limited. So we recommend that at national level, there had to be a national ART service in public hospital, and establish of ART guideline and of infertility and ART. We also recommend at the hospital level that they should make sure that cesarean section are being done when they are medically indicated, and that they should train health professionals on fertility care, as well as having institution treatment guideline and availability of ART in their hospital. We live with the community. We need to advise them that secondary infertility is common, and it's a risk factor, and as well as how they can be managed. So our study was limited because it was only from one hospital, and based on the study design, there could be difficult to establish a causal relationship. And also we depend much on their recall from their patient, depending on their fertility treatment. So this is not the end of the study. There can be further study that to be done, and we propose that there's a need to see what is the effect of cesarean section for future fertility, to understand the composition, the effect of fertility herbal medication that this patient have been used on their kidney function, as well as in order to establish ART in public hospital, we need to check what are the facilities and barriers. So these are references, and I'd like to thank my staff from Benjamin Kappa, the Department of Gyne and Clinical, which is represented by Hindu, she's also here. Thanks for coming. And I would like to thank for the patient who consented, and that's my email, because I'm a junior researcher and very passionate in the field of fertility and reproductive health. I'm very open to collaborate with anyone who wants me to help me to grow in this field and become an independent researcher. So thank you very much.
Thank you. Thank you so much, Dr. Kasilika. This was a wonderful talk. So I'm still asking myself, if you cohabit or live with somebody for more than 10 years, you are more likely to be infertile. That's what she was telling us. So I wish you will, we're waiting for her to give us more info about that. So our last speaker is Dr. Florence Salvatore Calabam, and you'll be talking about the resuscitation skills, retention 1 year after implementation of frequent simulations in Geita and Shinyanga regions. Karibu Daktari.
Good morning once again. My name is Florence Salvatore Carabam. I'm affiliated with the MUHAS in the School of Public Health and Social Sciences, and also at Kariuki University in the Department of Pediatrics and Child Health, and also Haydom Lutheran Hospital in the Safer Birth Bundle of Care, which is an intervention with the aim of reducing early maternal and neonatal deaths in 5 regions in Tanzania. Therefore, I'm going to share with you the preliminary results, focusing on assessment of neonatal resuscitation skills retention 1 year after implementation of the Safer Birth Bundle of Care. So, neonatal mortality is still high globally, but up to 95% of these deaths occur in low and middle income countries. And the major characteristics of these deaths are birth asphyxia, complication of prematurity, and also neonatal sepsis. And most of these complications are associated with suboptimal quality of care, especially during the time of birth. Therefore, to address this problem, the Safer Birth Bundle of Care was introduced in order to improve the quality of care among these women and newborns. So the intervention is focusing on main 3 packages. The one is the training methods, whereby we use the low dose, high frequency simulation based training, which is usually done within the facilities where the intervention is being implemented. And so after training by the national trainers, also the facility champions within the respective facilities are trained, and then they conducted training within their facilities. And other intervention, the training and clinical tools, whereby we have the training tools which aid to improve the simulation experience using training. But also, this intervention include the neobit. This is the gadget which you put on the chest of the child to monitor the heart rate when you are doing ventilation, so that you don't have to stop ventilation and starting auscultating the heart of the newborn, which may impair the improvement during resuscitation. But also, we have a heart rate bag and mask. This one improves the ergonomics when you are resuscitating a newborn, so that you don't get tired easily during ventilation, especially when you need to ventilate for a long time. And then we have the neonatal life. This is a simulator, newborn simulator, which is connected to the phone or iPad by using Bluetooth, so that it can guide you when you are training, so that you can know where you need to improve, whether it's a heart rate or the pressure and etc. And also, we have continuous quality improvement efforts to make sure that we improve the training and clinical outcome. So the aim of this particular study was to assess neonatal resuscitation skills retention 1 year after implementation in Geita and Shinyanga region. So the study is the longitudinal study with a follow-up of 1 year. So after baseline training, to make sure that everyone is having adequate skill, we have to follow up them up to 1 year and then reassess their skills. The participants will have healthcare providers from the respective facilities, and the study sites were 12 selected facilities from Geita and Shinyanga, and these were single sites, 6 from Geita and 6 from Shinyanga. And most of these were health centers and district hospitals and also regional referral hospitals. So data were collected using HBB tools, and analysis was done by SPSS by comparing scores at baseline and also 1 year after implementation. So the training was done at different times because the intervention is a step-by-step design, whereby each region receives intervention at its own time. So that we can learn from one region before we go to another region. So the results, a total of 226 participants were recruited, and the majority of these were nurses and midwives. And overall, 77% passed the skills evaluation. So which means that anyone who passes or scores 75 or more of that was considered passing the evaluation. But there were significant skills drop, whereby at baseline, they have a mean score of 94.5. Well, after 1 year evaluation, it was 83%. So there are significant skills drop after that. So most of participants retain the skills, whereby 75% still retain the skills, but there was a significant drop. But this is not as lower as those previous studies, similar studies which have been done in Tanzania. For example, the evaluation study to evaluate the HBB program when it was introduced in Tanzania, it was found that those who were retained the skills dropped up to 56%. 6 months after initial training. So maybe to have been much lower if it was to be done after 1 year of implementation. So we recommend that this training methodology and improving tools can be used and also can be scaled up in other facilities in Tanzania. But for it to work well, we have to make sure that we look for the factors which are associated with skill retention and also explore the barriers and also facilitators of the implementation so that we can know what are the specific areas that need to be improved so that this methodology can be more effective. So we acknowledge the healthcare providers who participated in the study, the SBBC staff, regional and district health leaders, the Minister of Health, ProRaj, and also a lot of foundation for finding this study, and also Global Financing Facility for financing the SBBC intervention. Thank you so much.
Asante. Thank you, Dr. Kalabam, for this presentation. So may I really ask all the presenters to step up, please, to sit on the podium so that we can have a few questions for you. Yes, so when you're sitting there, make sure that you don't sit on the high, on the big chair. You might be exposing yourself to more questions. So I think we are running short of time. I'll give the floor 6 questions, and I am assuming that these will be very short questions, straightforward questions, so that, and I'm assuming that each one will get 1 question. So karibuni. Dr. Kedia.
Thank you very much. I think the presentation was very interesting and enlightening. I have one question. I didn't catch your name. The lady who did the study on infertility. Yeah, so your sample size was 341. If I remember correctly, I wasn't clear. The 341, is it 341 couples or 341 individuals? So that is one. If it is individuals, can you also clarify what proportion were males and what proportion were females? And then related to that, your average age on your study, the mean was 34. So this 34, is it 34 years were they females, or they are 34 were they males? Because this again has got implication on your interpretation of the findings.
Asante.
I'll stop there.
Yes, Dr. Naya and Dr. Professor Kalokola. So.
Thank you, everyone. Thank you, Chair. My question is directed to issues on neonatal resuscitation and skill retention. Do we have any contextual data as proxy determinants for barriers and enablers for retention of these skills? And how can we progress? Maybe as an expert to this, can you recommend something to start with as a starter package? Thank you.
Thank you so much. I have 3 questions to 3 different presenters. My first question will go to Asma. It looks like those participants who had high level of education and those who are employment have more knowledge, and they were quite ready to do pre-marital testing. How do you explain that? Because it's not a common practice in the antenatal clinic to do. So how do they acquire the knowledge? Because that might influence the intervention. The other question goes to Demetria. You said there was a high cesarean section rate. I wonder, you're comparing with which one? It was about 30% cesarean section. Is that very high? I'm not quite sure, so I wanted to know. And in fact, most cases were emergency cesarean sections. So maybe they were not timely. The other last question is about a drop. It goes to Florence. There was a drop after training, and you are doing supportive supervision. So how do you explain the drop? Because if you're doing supportive supervision, it means you're visiting them every time, updating their knowledge. So you don't expect to lose their skills. So how do you explain that?
Asante.
Okay, thank you. I'm Martin, fourth-year student from MUHAS. I have a question on the participant who presented about infertility pattern. So there is a point I see on the risks of infertility projected there. It was said that high level of education, it might lead to infertility. So I just wanted to know at what perspectives. But also, I have another question on somebody else presented about neonatal resuscitation skills retention of 1 year. So I want to know the training was done pertaining to resuscitation of neonates in term babies or preterm babies. If it's both, how about the outcome after that? Then it's involving the both pattern of preterm and term babies. Thank you.
Asante. I think I have more than 6 questions, and I would really want the presenters to answer these questions first. So can we start with the last one? Yeah.
Thank you so much for your questions. And the one was from Dr. Naya regarding the contextual issues that may influence skills retention. And I'm going to answer them together with the second question, which was on if there were supportive visits and mentorship, where there were a significant drop in skills. And therefore, actually, after 1 year of follow-up, we did this analysis, but we are still doing another analysis after collecting all the necessary information by using mixed models and also other qualitative research, so that you can identify what are those other features which may affect skills retention. Because we have facility levels, for example, there are the issues of leadership, there are the issues of motivation for participants to participate in those trainings. We have the issues of workload and the like. So we are contemplating that these things may affect skills retention. But we are in the next step of doing analysis. Maybe during the next conference, we are going to share what we will come out with. And this goes well with the issues of supportive visits. We expected that they are supposed to retain skills. Yes, 77% have retained the skills, but as we have said that there are in-facility or contextual issues and plus factor X that may affect the skills retention. So to answer that, and the first question, we are going also to explore that so that we can see what are those pain points which can be improved. And the training on resuscitation of preterm and term babies, yes, we did training for all of those, for both of them. And there is another study whereby you are trying to link the skills retention or the practice, the processes, and also the clinical outcome of patients who have been resuscitated. So we are going also to assess the impact of the intervention, especially the training modalities, on the survival of newborns, on neonatal mortality, but also the survival of those who were resuscitated. So we are going to have more of the dose when we meet again.
Thank you, Dr. Rabam. So this is a work in progress. I believe next year, in the next conference, we'll be getting answers to these questions. Yes, Karibu, Dr. Kasereka.
Thank you for your comments and questions. To start with the first question that was regarding the cohabitation and marriage for more than 10 years. So what we see that when the people cohabitate that long, they tend to have a poor sexual function, and that can also be contributed also with fertility, they have a fertility psychological stress since they are trying and they're not making it. So they tend to like having difficulty with their sexual function. So again, with more than 10 years, people tend to have marital conflicts on and off. These all can also contribute. So I also had another question regarding the sample size. The correct sample size was 385 and not 341. And that was among a patient. For us, the patient, we just term them as individual, not couples. So for female, there were 201, and male, we got 184. With the age, sorry, I just say the mean age of 34, but it was 34 with points. Because like for female, it was 34.88, and then for male, we're like 34 point something. So that was like the average for there were different mean. But in terms of the group, most of them were between 32 to 37 years of age. And then something else I've been asking about how higher education affects fertility. This can happen because most of the time when somebody is pursuing her career, let's say study or work, they tend to neglect their own family law. I mean, their role as a female or a woman, like a woman maybe to get pregnant, because like they'll find that it's tend to disturb with their career pursuing. So most of the time they say, okay, let me finish first my degree, or let me pursue maybe this kind of a work. Maybe let me go abroad to do something like working abroad. And then all of this, with time, your age is going, your age is not stopping. And we found that most of the fertility things is being related with age. The more you age, your fertility goes low. So with education, we need to be very smart. Like how we can pursue education at the same time being able to meet our fertility goals. So thank you.
So you have to make sure that you get your babies early after marriage, and then you don't go. I'm not sure. The second one is difficult. I don't know what she's going to recommend. After the presentation, you'll be able to ask her for recommendation. Karibu, Dr. Demetria.
Thank you for the question. I was asked when I'm saying the cesarean section rate is high, in which basis? So according to Tanzania National Demographic Survey of 2022, it indicates the cesarean section rate of the average of 12% in public health facilities. So for those health centers are the ones which are just allowed to perform this procedure, and having the cesarean section rate of 21%, about doubled the number. It is high for them. So we need to take precaution to do more studies. Why are they having those high rate, and then the association factors. Thank you.
Yes.
Yeah. Thank you very much for the question. So the question was, is the employed and level of education is high and it has a positive perception rate of 68%. So why the knowledge is low with 6.5%. So actually the questionnaire that I conducted for knowledge, it had questions on sickle cell disease and premarital screening. So the questions that were for sickle cell disease, it showed that they had no knowledge regarding the treatment and cure. Majority of the people who participated, they thought that there is treatment and cure for sickle cell disease, which is not right. Another thing, they thought that people who appear physically normal, they cannot give birth to a sickle cell child, which is also not correct. So these all points carry towards incorrect answers, and this made that along with the questions related with premarital screening questions, majority of them, they agreed that yes, it should be done before marriage. But then along with questions with sickle cell disease, it gave the knowledge to be inadequate of 6.5%. Thank you.
So the first presenter wasn't asked any question, second. So thank you. I think I would like to end here because we have encroached into the time of the next presentation. May I ask you to give a round of applause for the presenters? Asanteni. So for those who wishes to stay here, it is still on maternal, newborn, and child health and adolescent health. And then there's Benjamin Mkapa Hall for non-communicable diseases, mental health, surgery, and nutrition. And then we have Jakaya Kikwete Hall for health systems, research, and NCDs, and John Magufuli Hall for non-communicable diseases, mental health, surgery, and nutrition. So that's the next session after this one. So for those who are staying here, they will continue to hear about maternal, newborn, and child health in adolescent.
Good morning, everyone. Maternal and newborn, maternal child. Yeah, napa bias na newborn. Maternal, newborn, child, and adolescent health. We are still here. Can we have our presenters in front? Can I have Tekla, David, William, Gertrude, and Mwajabu? Wameshakuwa present? Yeah. Yes. Good morning, everyone. Can we start? We have 5 presenters and we almost have less than an hour. Can we have the first one, Dr. Tekla Marisham? Tekla Marisham will present on factors influencing menstrual hygiene practices among secondary school adolescent girls in Kisarawe. Tekla, where are you, Tekla? Do we have Tekla? She's not here? Okay. So for the sake of time, can we move to David? David will be with us and presenting on visual acuity problems, access to care, and related academic performance among primary school students. Sorry, we are trying to sort out one of our presenter will be joining online. The tech part are advising us to proceed with David. So David, welcome. We give ourselves 10 minutes for presentation,
Okay,
and then
thank
we'll park the discussion together.
Thank you. I'm going to present on visual acuity problems, access to care, and related academic performance among standard 7 students in Dar es Salaam. The background for this study, globally, research found out that in the low resources settings, we have high burden of high health problems, particularly among adolescents, and vision as one of the components of overall health. Eye health can be divided into near visual acuity and distance visual acuity. In Tanzania, 1 in 10 individuals age 15 and older have some kind of visual impairment. Up to 8.8% of adolescents aged from 6 to 19 years older, they consider themselves to have poor vision. Our research question is based on the prevalence of poor distance visual acuity among young adolescents in Tanzania, the relationship between distance visual acuity and academic performance for young adolescents, the facilitators and barriers to school-based visual screening, and facilitators and barriers to young adolescents receiving critical eye care. This study is based on the comprehensive adolescent wellness visit study, which was conducted in Dar es Salaam and Bagamoyo. The study is a randomized control trial for 20 schools, 10 in Bagamoyo and 10 in Dar es Salaam, into intervention and control. So this part of the study only took the findings from the intervention data. So we collected the data from the baseline and 12-month follow-up survey. We used the academic examination scores for primary school living examination. We use vision screening, medical chart extraction. We also use focus group discussions with teachers, adolescents, teachers, healthcare providers, and we also did in-depth interviews with parents. The scores were 6 out of 6 or less were considered as normal vision. 6 out of 7 to 6 out of 11 were considered as moderately reduced vision. And for this, the discretion of the provider was used to give referral. And 6 out of 12 or above was considered as poor vision, and these students were required to be given referral. Here are our findings. We found out that 88% of the study participants had normal vision, and there are more students in Bagamoyo, which is of rural setting with moderately used or poor vision, than in Dar es Salaam, which is more of an urban setting. We also found out that 2/3 of the students with moderately reduced vision or poor vision had received grade C, while half of the students with normal vision did receive grade C. As we see it in our table, that 65.7% received, poor vision, 68.2% with poor vision has received grade C, and the number has been going down from moderately reduced to normal vision. 9.3% of the students referred for follow-up care had seen an health clinician 1 year later. If you look at chart there, out of 12 who were referred, only one with poor vision, with normal vision, had seen the healthcare clinician. Out of 11 who were referred, only one had seen the eye health clinician. And out of 20 who were referred, only 2 had seen the healthcare clinician 1 year later. So these are qualitative findings. We found out that school-based vision screening were largely successful in identifying problems and encouraging parents to pursue eye care. Teachers were feeling that it was felt that it is sufficient to conduct screening. The training they received, we trained the teachers on eye screening, and they felt that the training they received was sufficient. Some parents were able to follow up on referral, but there are also some issues with such as environmental factors, as the screening was conducted outside, which was creating challenges during the administration of the screening. This is facilitators and barriers for accessing critical eye care. And there was disconnect in referral linkages between nurses, teachers, and eye health clinicians. As we've seen in our chart there, very few of the students who were given referral had gone to see the eye health clinician. This was due to the structure of the visit. Healthcare providers at the intervention lacked the ability to follow up with the families, while teachers weren't privy to medical information. Teachers were, this is because of the ethical issues, so teachers could not access the medical information. Also, parents could not afford the price of the eye care for their children. So some parents could not take their children to go for AWV for the referral because they could not afford the price of glasses or other vision wellness check. Also, parents did not understand the importance of clinical eye care before the vision screening. Some parents could not take their student, but if their children could complain about the vision issues, the parents didn't consider it as an issue. So in the discussion, we feel that school-based vision screening is a very important step in enabling students to get eye care they need. Currently, there is no mandate for students in schools to conduct vision screening. Eye care services available to young students is severely limited, and some with poor vision were not referred due to already being receiving their treatment for their condition. We recommend that, given our finding, the government should consider requiring school to conduct this distance visual screening. And also further research is needed for optimal implementation of strategies. Also, screening in the last year of primary school is too late. So we recommend that screening should be done early in the school entry and maybe during the midway. This is the end of our presentation. Thank you.
Asante. We will take some questions later. Please note the questions. Thank you, Dr. Dr. David. Can we have the next presenter, Dr. Gertrude, and then we'll have William last. Gertrude first, yes. And then Mwajabu, and then we'll welcome William online. Please note your questions. We will have the discussion after all the presentations. Do we have Tekla? On behalf. Anyone representing Tekla? Oh, okay. Okay, after the presentation from Dr. Gertrude, then we'll have you. Karibu, Dr. Gertrude, 10 minutes.
Good morning, ladies and gentlemen. I'm delighted to be here today to present to you results of the study titled Prevalence of Anxiety and Depression, Correlation with Emotional Dysregulation and Risk Factors among adolescents aged 10 to 19 in Dar es Salaam. And this was a mixed method study. And this will be the outline of my presentation and straight into it. So for this audience, I'm sure I don't need to really state how much adolescence is a critical developmental age. It's an age where a human being forges meaningful habits, meaningful relationships that influence so much their adult lives. But also developmentally, it's a very critical age for both physical and cognitive development. And needless to say, this is an age where the onset of various diseases, both communicable and non-communicable, the risk to acquire the diseases is high. And the same for mental illnesses. These account for 13% of the global burden of disease in this age population. And it has been shown that even though 50% of mental illnesses that we see among adults actually started by the age of 14, almost 3/4 of them are not diagnosed and treated during this time. And emotional dysregulation, which is defined as an inability of a person to mount an appropriate emotional response to a trigger and successfully go back to their steady state emotional status. This has been shown to increase the risk of onset and persistence of mental illnesses and among different populations, including adolescents. And depression and anxiety, which are key topics of interest today, among the commonest mental illnesses reported in this age group. So the broad objective for the study was to look at the prevalence of anxiety and depression, the correlation of these disorders with emotional dysregulation, what are the associated factors, and those spoke to inform our specific objectives, and additionally was to explore what were the perceptions towards mental illnesses among adolescents themselves, parents, and teachers. As stated earlier, this was a mixed method study that we conducted in 5 municipalities of Dar es Salaam, including adolescents aged 10 to 19 years inclusively. And the analysis was done by using Stata, and we employed different statistical methods, as I'm going to state in various result sections. So tools that were used, we used PHQ-9 for depression, GAD-7 for anxiety, and DERS-18, which is the disorder for emotion regulation tool for assessment of emotional dysregulation. And quantitatively, it was a cross-sectional study, and for qualitative data, we used focus group discussion and in-depth interviews. So off to the participants that we recruited, we managed to obtain parental consent and assent from 1,245 participants, but 123 of them were excluded because the documented age was found to be above 19 years, which was outside the study population of interest, and 11 of them did not have a complete data on any of our primary outcome. That left us with 1,100 participants, which were distributed across different municipalities of Dar es Salaam as shown, and the distribution was guided by population proportional to size sampling methods. And of the 1,100 participants, around 1,000 completed PHQ-9 and GAD-7, and 800 completed DERS. So off to the characteristics of the participants we included, our median age was 16 years, and there was almost equal distribution between the three categories of adolescents. We had almost a third, slightly over a third between 10 to 13, and then middle adolescents around a quarter, and the rest were older adolescents. And primary caretaker were both parents for 64%, and 85% had both parents alive. But as you can note, only 25% of our participants had their parents, 25% of our participants had their parents not living together. And for the DERS score, 21% scored above 75th centile. A little more of the characteristics, 15% of our participants were overweight or obese. And looking at exposures to adverse, social adverse events, 14% of participants have ever witnessed their parents fighting, 12% have ever slept without eating due to lack of food. And the time spent between commuting between home to school was a median time of 30 minutes. So going to our primary objectives, which were prevalence of anxiety and depression. Starting with depression, 35.8% of the participants had any form of depression all the way from mild to severe, but 11% had moderate and severe forms of depression. The same was observed for anxiety, where 35.2% had any form of anxiety and 10% had moderate and severe forms of anxiety. And beyond just looking at the burden, remember, we also wanted to look at how these disorders were correlating with emotional dysregulation. And we assessed emotional dysregulation in different areas. And there were different domains, including non-acceptance of emotional response, difficulties in engaging in goal-directed behaviors, impulse control difficulties, lack of emotional awareness, limited access to emotion regulation strategies, and lack of emotional clarity. And the bar graphs that you can see, or you can't see my pointer, but okay, I'm going to try to explain to you. So for all the bar graphs that you can see, that shows the median DERS score on your y-axis on different categories of severity of anxiety. So the first group is for non-acceptance, and you can see the median score increases as you increase the severity. Blue is for no anxiety, and then it goes to mild, moderate, and severe forms. So we observed increase in median scores of emotion dysregulation as you increase the severity for anxiety, and this was statistically significant except for the domain of lack of emotional awareness. And on Kruskal-Wallis correlation, on the Spearman rank correlation coefficient, we also saw a moderate correlation between anxiety score and emotional dysregulation score. This is to say, for each increase in emotion dysregulation score, there was a moderate corresponding increase in anxiety scores as well. And this was similar for the observations in depression. We were observing increase in the median scores as we increase in severity of depression, except for the lack of awareness subclass, and the correlation between the two was also moderate at the Spearman rank correlation coefficient of positive 0.33. Now off to the factors that's associated with depression. So those participants who had only one parent alive, or both parents being deceased, had 3 times higher odds of having depression, and this was significantly, statistically significant with p-values, as you can see. Similarly, participants who had ever observed their parents drunk had 6 times higher odds of depression, and those who have ever witnessed their parent fighting had also 2 times higher odds. And those who had emotional dysregulation above 75th centile also had close to 7 times higher odds of having moderate and severe forms of depression. Additionally, we observed that the longer the time, commuting time between home and school, this was also correlated to increase in the odds of moderate or severe depression. Off to anxiety. We observed that participants who were enrolled in private schools had 65% higher odds of anxiety, and this is moderate and severe forms. And also similar to what we observed in depression, those who have ever witnessed their parents fighting also had twice as much higher odds of of anxiety, and also having a higher emotional dysregulation scores. So those were the outcomes that we explored quantitatively. Going off to perception that we explored qualitatively, I would wish you to recall that the proportion we observed was above 30% for both anxiety and depression. But when we asked the participant what they felt like was the burden of these disorders, some of the participants actually perceived that the problem is rare among the adolescents. So although some could cite the rising burden, some could also say that they feel like it is rare for adolescents to have depression or anxiety. And additionally, they felt like most of the disorders that would look like anxiety and depression could relate to witchcraft in the community. And this could stem from when neighbors or relatives feel envious about your well-performing adolescent, they tend to bewitch them. Other factors, we group them into societal, family level factors, school and peer-related factors, as you can see in the table above. But in the community, it was normalization of harmful habits such as betting and access to cheap alcohol and lack of parental supervision. And also family level, extreme poverty and family separation was perceived as risk factors for anxiety and depression among adolescents. At school level, bullying, but importantly, stressing on having good academic excellence and forgetting other aspects of a well-rounded individual, such as social well-being, was termed as a risk factor for mental illnesses among adolescents. And peer influence in engaging in substance use, including smoking and alcohol, betting and gambling, unsafe sex practices, and pornography were perceived as risk factors. Furthermore, participants commonly mentioned that a person will be perceived to have mental illness only if they displayed features of psychosis. So if you're not, you don't have psychosis, you don't have mental illness. And features of such as depression, anxiety would mainly be related to lack of maturity, relative lack of maturity for adolescents as compared to other population group. And stigma was also common. And for adolescents, they cited that young people see it as a waste of time to disclose their status when they're having emotional distress. And this is because they perceived facing stigma from the people they open up to, and in this case, are discipline teachers at the school. So from this study, we observed that 3 in every 10 school attending adolescents had depression or anxiety, but to the contrary, there was a low perceived burden when we talked to them about their perceptions. And misconceptions about mental health were common, and exposure to social adverse events such as poverty, witnessing parent fighting, and also witnessing parent drunks were among the factors that were associated with higher odds of anxiety and depression. Additionally, peer influence and excessive academic pressure was noted. So strength of the study included the fact that we were able to include over 1,000 participants, which was a relatively large sample size that also led to precise results with narrow confidence interval, but also regional representativeness of PPS sampling across the 5 municipalities with a Riga methodological triangulation. However, we were not without limitation, and these included recall bias. Our participants had to recall events in their lives, had to feel the tools, recall over a period of the past 2 weeks, but also desirability bias, where participants could have attempted to respond to the way that they felt was perceived as normal in the community. But also having a participant having no response in the main outcome could have swayed what we observed as the proportions. In conclusion, anxiety and depression are both prevalent in a population of school-attending adolescents in Dar es Salaam, and emotional dysregulation correlates positively with these disorders. And with regard to the explored factors, there is need of collaborative efforts between parents, schools, and community in order to address these disorders. Hence, we recommend looking into school screening programs for mental illnesses among adolescents, but also enhancing their emotional well-being, together with building a well-rounded adolescent, not just academic excellence, but a socially functioning adolescent as well. And also building awareness to these in the community on what is the true burden of these disorders among adolescents and the risk factors, and also using the factors that we saw increasing the risks to co-create interventions to address these disorders among adolescents. Heartfelt acknowledgements to the adolescent and parents and teachers who participated in the study. My supervisors, Dr. Kija, I acknowledge your presence, and the councils that offer authorities and the organizers of the conference. Thank you.
Thank you, Doctor, as usual. Thank you. So touched by the presentation. Can we welcome our first presenter, Dr. Tekla, who will be represented by her colleague, Bazile. Yes, welcome, please. Did you load your presentation?
Yes.
Okay, please welcome. And she will take us through the factors influencing menstrual hygiene practices among secondary school adolescent girls. Karibu, we'll have 10 minutes.
Okay, thank you. My name is Bajile, and I'm representing the work of Tekla Marusham with the title Factors Influencing Menstruation Hygiene Practice Among Secondary School Adolescents Girls at Kisarawe District. Globally, there are 2.3 billion adolescent girls around the world are unable to manage their menstruation period. And approximately 10% of African school-aged girls do not attend classes during their menstruation monthly period. But also, unsafe menstruation hygiene practice increase the risk of infections such as UTI. And in Tanzania, the study done at Kibosho also revealed that about 30% do not use sanitary pads during menstruation period. Also, at Kisarawe district, this is among the Tanzanian district, reported facing significant burden of limited water supply. Problem statements also. However, the problem of menstruation hygiene practice among adolescents at school still reported with high rate of informed and associated factors. And therefore, this study was aimed to determine the factors influencing menstruation hygiene practice among the school secondary adolescents at Pwani, Tanzania. The research objectives were to determine the factors influencing menstruation hygiene practice among secondary girls' schools with the specific objective that is to describe menstruation hygiene practice among secondary school adolescents in Kisarawe, also to determine student-related factors associated with menstruation hygiene, also to determine the socio-economic factors associated with menstruation hygiene practice among secondary schools in Kisarawe, but also to assess the related factors associated with menstruation hygiene practice also in Kisarawe. The study area was Kisarawe, and the study design was the cross-sectional study. Also, this study population was the girls aged 10 to 19 years. And also the inclusion and exclusion criteria for those girls who has not yet started seeing their periods, they were excluded. But also they used stratified random sampling, and they used students at Kisarawe. Data analysis and presentations. Data analysis was done using data vision of 70. Also, from the objective, we have variables and independent variables. And this now is the table of results. The school students, girls which were engaged from Form 1 to Form 4, it is characterized in two groups. Form 1 and Form 2, it seems 60% has at least have the knowledge and has also used those sanitarian pads, and Form 3 and Form 4 also. But also we have the school locations, the rural area and the urban area. In rural, at least we have 82%, but in urban area, it is only 11%. Also, menstruation hygiene and safe practice use the sanitarian and frequent change as shown in the table. Also, awareness about the menstruation materials to be used and allergic to some menstruation materials. Also, the free, embarrassed, or stigmatized about their periods. Also, not feeling comfortable using menstruation pads. These all were asked through questionnaires. And you can see that it is very low. It is 0.0.4. So this is very low for our girls in schools. But also we have the last variable, which is school locations. We start with school ownership, availability of safe and accessible water supply. Some of areas there is no water supply, and some of areas the water is not clean. And also the ways to dispose of those sanitarian pads after using it. Those knowledge on how to dispose it, and do they dispose it well? Part of discussion. Significant proportions of girls practice unsafe menstruation hygiene factors. Menstruation hygiene factors associated with unsafe practice, such as low classes from Form 1 to Form 2, allergic to some certain material of those sanitarian pads, also discomforting using those pads, but also lack of discussion with parental guardians about their menstruation health. School located in rural areas, and also the public government schools. Also, menstruation hygiene practice, significance of girls undergo unsafe menstruation hygiene practice is about 68.2%. But also study done in Australia, shown also 50% has unsafe menstruation period. In Nigeria and Ethiopia also have some percentage, which it is like equivalent with this study. The implications, this implies unsafe menstruation period hygiene remain problem in many settings that call for regular interventions. Also, factors associated with unsafe menstruation period practice, like allergies and menstruation hygiene practice, discomforting with menstruation pads. Factors associated with unsafe menstruation hygiene practice, limited sanitation pad, school are located in those rural areas. If you compare with those located in urban areas, you can see those differences. Also the public and government schools, but also availability of clean and safe sanitations did not significantly affect menstruation hygiene practice. Construct with previous studies in Tanzania and Ghana. A significant number of girls are involved in unsafe menstruation hygiene practice. Also, these unsafe practices are influenced by various factors such as young age, lack of awareness. As you can see that parents are not speaking with children about their health, but also allergic, feeling comfort or discomfort, health corners, school allocations, whether it is urban or rural, and also type of vulnerabilities. Addressing menstruation hygiene requires comprehensive interventions, considering multifaceted factors of unsafe practice. what recommended is comprehensive menstruation hygiene education program in schools should be at least provided. Improve school environment with better water supply and sanitation facilities in order to help this group of students here, about 10%, as we see, as you already passed, that they fail to attend schools during their monthly period. But also consideration for future researchers, this is qualitative research through observation to rule the issue of sanitary and fertilities to explore experiences of secondary school adolescent girls with their mental practice. But this is quantitative, but qualitative can also do better about it. A comprehensive intervention to improve menstruation hygiene practice among secondary education girls also is very important. And thank you for listening all.
Bilije Bajile. Thank you on behalf of TECLA. We will have our last face-to-face presentation from Mwajabu. She will be taking us on the experience of mothers caring for babies, infants with neurotube defects at one of our orthopedic trauma center in Tanzania. And then we'll have one presenter online. After that, I think we'll have a discussion for all the presenters. Karibu Mwajabu.
Good morning. Before my presentation, allow me to give you a kind of a short story on how I ended up with this topic. So in my daily ward activities as a resident, I was passing ward rounds, and in seeing 40 patients, 20 of the 40 patients were mothers with babies with neurotube defect, and they were desperate. They did not really know what was happening. For some, they didn't even know what was the cause. So allow me to take you through, we endure greatly, experiences of mothers in caring for infants with neurotube defects at Muhimbili Orthopedic Institute. I am Mwajabu Idi, I'm a third-year resident, and I will be presenting on behalf of Belinda Balandia, Brian Muro, Prof. Dr. Kakoko, John Tay, and Amani Kikula. So children with congenital anomalies, especially neurotube defects, which are the most commonest congenital anomaly, only second to cardiovascular defects. So they are associated with long-term disabilities, which could be paralysis, incontinence, and learning difficulties. Now, these causes are a significant care burden to the mothers, as the prevalence of the neurotube defects globally is around 5 per 1,000 newborn, and in Africa, it's 8.4, and in Dar es Salaam, in a recent study done, it's 9.9 per 1,000 newborn. So we see the burden is still big, it's high. So this causes a significant burden to these mothers, and it has an impact on their quality of life, which in turn impacts the quality they give, the quality of care they provide to their child. So my main objective was to describe the experiences of mothers who are caring for infants with neurotube defects, with specific objectives of exploring the psychological and physical experiences, the social experiences, and economical experiences of mothers caring for children with neurotube defect who are admitted at Muhimbili Orthopedic Institute. So on the methodology, the study design was a phenomenological explorative qualitative study, owing to the nature of the study that I was describing the experiences, and these are intimate. So the study sample was mothers whose infants are admitted with neurotube defects at neurosurgery ward 5B at MOI during the study period of December to May, within 6 months. Who are within 6 months postpartum. And the sampling technique was a criterion-based purposive sampling done, guided by the principle of information saturation. And data collection, 10 in-depth interviews were done, which were conducted by using a Swahili guide translated from the original English guide. And after consenting of each participant. So data analysis was done deductively. So a deductive data analysis was done by using Brown and Clark 2006. So ethical consideration, ethical clearance was sought from the MUHAS IRB and permission to conduct study during data collection, and also an approval from the Director of Research from MOI. So on the results, three essential major themes were developed, which were economical experiences during postpartum, which had two sub-themes, the financial implications and financial support by significant others. And another theme was postpartum psychological and physical experiences by these mothers, which encompassed physical experiences and emotional experiences as sub-themes, and also postpartum social experiences of mothers, which had several sub-themes, including changes in mothers' daily activities, the acceptance of child's condition, the issues on healthcare, and mother's social support system. So as a representation of the economical experiences, as I quote, one of the mothers said, "We have been affected a lot financially. All the money earned is directed to the hospital bills. We have sold everything we own, but still it's not enough to cover the bills. My other children have been kicked out of school due to lack of fees." So this was participant 10, a 36-year-old para 4. So this shows us that the care these mothers have to, the care for these children, the infants with a neurotube defect, they have a significant economical toll on these mothers. And this is mostly owed to their overwhelming medical bills that they have. Also, on the postpartum psychological and physical experiences, one of the participants said, "I was wondering what causes this problem. And yes, my child has been operated on, but how will the growth be like? Will my child ever walk? Or what will be my child's future? I feel so helpless and cry a lot when I think of this." So this was participant 1 at 22 years, para 2. So this was part of the major problem. Most of the mothers caring for these infants, they really didn't know what was happening. They really didn't know about neurotube. They didn't know what caused it. They didn't know what the future hold for their infants after they have been operated on. Also on the postpartum social experiences, a participant said, "The challenges is we have become a laughingstock in the society. They say, oh, you have delivered a baby with a wound. It won't survive. It will die in less than a week. After that, I just sit by myself at home, cry." So this was participant 8, 29 years, para 2. And this shows that still in our society, we are not really, also the society is not really aware of the neurotube defects, and they shy away these women, they isolate them, they go through discrimination. So for some of the mothers, they were not even comfortable with sharing that they had babies with neurotube defects. So in conclusion, the experiences of mother caring for infants with neurotube defects are complex and multifaceted. So in addition to providing direct care for infants, mothers also face various challenges that can impact their ability of care. So these challenges include economic, social, and psychological factors. Now, what can be done as a recommendation? There's a need of a comprehensive integrated care plan, which could be initiated by the government or the hospital, and mostly implemented by the hospital through with the aid of health stakeholders. And this plan should be multidisciplinary in that there's a need, as seen in the study, for psychological support, economical support, especially in encountering the medical expenses. So also, there's a need for the counseling on diagnosis of these women on the diagnosis. What will be the prognosis of the babies after that? And also continued and enhanced support of health services, patient advocacy groups, providing additional information and support. There's currently one group. There is a group called ASFAT. Now, this is an association of parents with neurotube defects and hydrocephalus, but this is just one group, and it's currently in Dar es Salaam. And the neurotube babies, they are all over Tanzania. So there's a need for creating these groups, just like ASFAT, the one which is in Dar es Salaam, to the rest of Tanzania, so as to support these women, provide them with information and guidance. So from diagnosis to pregnancy, postpartum, all so as to ensure effective and efficient care of children with neurotube defect. Thank you for listening.
Dr. Majabu. Now we welcome William Mwakalasia, and he will be taking us through the horticultural farming and the hazardous pesticides issues. Please jot
Thank
down
you.
your questions. We will have the discussion after the last presentation.
Thank you, moderator. Should I share the slides from my end, or you are going to share on your end?
In seconds, I think we are about to connect. Can you share your screen now?
All right. Can you see my screen?
Not yet. The tech team is working on it. We will pin you soon.
Okay.
Sorry, kindly bear with us. Dr. William, kindly give us some few minutes.
All right.
As we are setting up William, please jot down your question. Remember, we had how many presentation? 1, 2, 3, 4. 4 presentation already. The last one from Mwajabu about experience of mothers caring for infants with neurotube defects. We had Gertrude, prevalence of anxiety and depression, and risk factors in correlation to emotional dysregulations among adolescents. And then we had David on visual acuity problems in relation to access to care versus academic performance. We had Tekla on issues of menstrual hygiene practices among our girls in secondary school education. And now we are about to welcome William to take us through the experience from the mothers raising children around the horticultural farming areas. Welcome, William. We'll have 10 minutes with you. You can start now. We see your screen and you are good to go.
Oh, thank you. Good morning, for those who are physically in the venue, and whoever in other participating countries, greetings to you. I'm presenting to you part of a big study. And on this study, I'll be presenting on a qualitative study title, Growing Up Amidst Hazardous Pesticides. This is an experience, it's reporting experiences from mothers raising children while working on horticulture farms. It's a qualitative study. Sorry, I can't advance my slides. Oh, it's moving now. In Tanzania, horticulture industry is blooming nowadays, and in it, majority of workers are women. It constitutes about 70% of the workforce. And unfortunately, this sector is associated with an intensive use of pesticides, which as a result expose women and their children to these hazardous pesticides and the pesticide-related health risks. So given that women often serve as primary caregivers to children, this study explores the experiences of mothers in nurturing their offspring while within these highly, and mind you, some of the pesticides that we are registered for use in Tanzania are known to bear these two unique properties, the neurotoxic and the reproductive toxicity properties, which means upon early life exposure, these children will have an opportunity to get a maternal placental transfer of these pesticides and get exposed at their early stages of life. So the study, as I said, it was a descriptive qualitative study, which was done in Bagamoyo, Pwani, Mvomero, Morogoro, and Mbarali, Mbeya. And it involved women with children aged 4 to 6 years who have been living in the horticulture community since before their children's birth. And we specifically chose this age category because the study also involves studying the neurodevelopment and the behavioral development of these children at this stage of life. And data was collected via focus group discussions. We are using some structured interview guides. And it was analyzed using inductive thematic analysis techniques where we identified themes from the data without any prior preconceptions. We managed to do 5 focus groups, and each group had a minimum, a range of participants ranging from 6 to 12, with a maximum participants of 12. And we had a mixture of women. Some of them were married, others were not, and others were, the maximum level of education was secondary education. And we had few women who didn't manage to attend any formal education. The study came up with 3 main themes. The first theme is gender roles in horticulture work. We had a second theme, we work when pregnant or with a young baby because we are poor. And the third theme was our children are not safe from the effects of pesticides. With regard to the first theme, we realized that the study found that horticulture roles in these communities are decided based on their tradition and practicality. And in married families, men tend to do physically demanding and those tasks which are known to be potentially hazardous. These are the tasks which involve a direct spray or mixing of the pesticides. And on those families, women are allocated to roles which are socially perceived to be easier, such as planting, pruning, and weeding. But in families where women are alone, unmarried women, we found that they try to manage to handle all the tasks themselves. That means they can mix, they can spray, and they can do all those tasks which are perceived to be easier for them. As it was reported by the second participants from one of the study sites, saying, depending on the circumstances, there are certain tasks that women cannot do or certain tasks that men cannot do. And we help each other accordingly. Sometimes there are situations where women are not supposed to handle pesticides, but if it becomes necessary and there is no one else available, women do so. Under the second theme, which is named "We Work When Pregnant or with Young Baby Because We Are Poor." In this theme, it was found that during the pregnancy period, women continue working because there's a family that depends on what they will earn from the horticulture farm. If they decide to stop, that means their family will starve. So if a woman is the sole breadwinner of the family, that means that woman will have to do everything, regardless of whether she's pregnant or she's nursing a newborn. And this financial constraint also denies women time to heal and nurse their newborns, because some women reported to return to farm while their baby are still very young. As reported in this participant number 7, she said, it depends on your health, just like it does on mine. If I'm in good health after giving birth and my baby is healthy too, I can spend my 40 days and then resume work as usual, considering that situation of life. So you see, this a postpartum mother who just got a newborn, after 40 days, she has to go back to start handling these hazardous chemicals with a newborn on her side. And at the farm, mothers must now strike a balance between horticulture work and child care, because this child is very young. She can't leave her at home, her or him at home. And some tasks are managed while carrying the child on their back, or otherwise they'll seek a shaded spot on the farm or nearby to lay the child down. Under the third theme, our children are not safe from the effects of pesticides. Our study found that regardless of the task being performed, it is done in the presence of the children. There is nowhere to let this child go, whether it's a newborn or it's a grown-up child. So if a child needs attention while the mother is spraying, they try to do protective, that is mother instinct. They protect their children by washing their hands before handling the child. But that depends on the urgency of the child's needs. Sometimes the mother, whether she was praying or weeding or whatever she was doing, she would just rush and attend the child while she is contaminated with these deadly neurotoxic and reproductive and pesticide-bearing reproductive toxicity. As it was reported by one of the participants that we can't say that we seriously wash our hands because we did not go to the farm with soap, only if you might. It's only God's protection, because you find that someone sprays pesticides today and the other day after tomorrow, they are harvesting tomatoes. Both tomatoes we harvest mostly have pesticides, and you work with the child around. When the child cries, you quickly rush over to pick them up and breastfeed them or give them food. There is no soap or anything. It is only God who protects us. So this is a quotation from one of the participants in the discussion. And these are just a few newborns. But for older children, preschool children, these children are in a more serious danger because they have access to empty pesticide containers, which they sometimes use during their childish plays. And mind you, these pesticide containers are also considered to be hazardous because they bear these toxic pesticides inside. So there were also some reports of children using the containers to fetch water from the irrigation streams and even drank from them. So these children get exposed during early life of fetal stages of life, get exposed during a nursing stage of life, and later in life, they'll keep on roaming in these farms and getting exposed to these hazardous pesticides. So these are the experiences we got from these mothers who have to take care of children in these horticulture farms. So my conclusion is children raised in these horticulture communities are consistently exposed to pesticides from a very young age, from the fetal stage. And exposure to pesticides in these early stages of life might have detrimental health consequences later in life. We are experiencing a blooming increase of non-communicable diseases, some of which we don't have a serious cause relationship, cause-effect relationship. And these pesticides might be also contributing to the burden. So therefore, educating women on safe pesticide handling and use is necessary for protecting children from potential long-term health consequences. This is only because we can't afford to say no to pesticides currently, but at least we can try to reduce the amount of these pesticides bearing neurotoxic and reproductive toxicity before reaching these vulnerable young children and pregnant women. Thank you very much. Moderator, back to you.
Dr. Tekla, representative, you want to room in for her? No? Okay. So your questions, audience, do we have an extra mic with us?
Information. Would you consider
So actually, I wanted to ask on the part of qualitative approach as you were collecting the data during the interviews with the adolescent participants. Did you, by any chance, encounter the role of long disease? I mean, the disease burden or long treatment pathways if they could have encountered in one way or another to anxiety and depression towards the adolescents who are schooling, if there is any role for that, and if yes, how could you account for that? And another question is, currently there have been a program in some of the areas in our country trying to advocate for teen mothers, those adolescent females who have been schooling and unfortunately they got pregnant and they had delivered already and they're trying to be back to pursue to resume their academic journey. So as they are resuming their academic journey and they're trying to cope with studies, to catch up and thriving for their excellency, for their academic achievements, could they be subjected to anxiety and depression by any chance? Like they've not been for studies for quite some time. How could they catch up and still perform well like other teens? So maybe if you can account for that in relation to your study. Thank you.
I think
Yes, thank you very much for a very nice presentation. My question is on adolescents' anxiety and depression. She said about 65% of the private students has depression and anxiety. I would like to know what exactly is the cause of depression and anxiety in private schools, because a lot of us do take our children to private school and we want to know what exactly is the problem. Thank you.
Thank you. Now you're creating anxiety to us. Any other question?
Here.
Oh, okay.
Okay,
Turn us.
so thank you, Chair. I would like to direct my question to William regarding the horticultural aspects. So the way he has presented, it's like there is no any regulation for those people operating in the horticultural industry. So I'd like to ask if there are, what's the influence and what's the role of regulators in these horticultural farms? Because if someone can go there with a small baby and all that, it looks like it's business as usual. So are there regulators and are the regulations working? This is my question. Thanks.
Yes. My right side. That will be the last one, and then we can respond. If we have more time, we'll take another round.
Thank you, the presenters, and thank you, Gertrude, for the presenting us on the issue of adolescents. I realize, like you told us, like you had a primary and secondary school students, but the one that participated for you were 10 to 19, though the age that started were 12. So you wanted to know those who are 10 to 12, you did not, 10 and 11, you did not include them when you go to primary schools, or what happened? And then the second question on the emotional dysregulation tool that you used, the participants who responded to that tool were 819. So what happened to, because you had the more than 1,000 participants, and for PHQ9 you had 1,023, but for the emotional regulation tool they were more or less compared to the other two. So what happened? Those were two questions. Thank you.
Thank you. So before you proceed responding, I also have one extra for Gertrude. Did you have any measures to tackle ethical issues in terms you have emotional dysregulation erupting in between the sessions? Thank you. So maybe we can start with Dr. Mwajabu. You had one question from Professor Kalokola.
So thank you for your question that on the concerns of the associated malformation. Now, on the Tanzanian Penal Code, it allows termination of pregnancy in good faith and with the autonomy of the patient. Now, with neurotube defects, they are actually divided into two. We have those of the cranial defects and the spinal defects. Now, for most of the part, the spinal defect, neurotube defects, they are usually treatable. So with the current Tanzanian Penal Code, it's actually not allowed to actually even advise the patient to terminate pregnancy. But if the patient is willing, for the ones of the cranial, especially for the encephalocele, since their survival rate is almost zero and the babies die soon after delivery. So here there's a room for the mother to decide. But again, with the current penal code of Tanzania, we cannot really advocate for that. Perhaps maybe here is the room for maybe a change of the penal code, because the burden these women go through is a lot. Thank you.
Thank you. Dr. Gertrude.
Thank you very much for all the questions, and I'm going to respond to the best of my capability. The first one was about whether we explored the contribution of chronic diseases in mental health of these adolescents. So quantitatively, we did not include that in the variables, but qualitatively, among the perceived risk factors that emerged in our detailed results, yes, having chronic illnesses was perceived as a risk factor. And the second question is about teen mothers and whether them being a teen mother is put them at higher risk for mental illnesses. I would say yes. Although in our participant, we did not have any of a teen mother returning to school. However, this is a specific population that already has specific risk for mental illnesses. First of all, they're adolescents, they have undergone pregnancy, they have the first an additional burden of taking care of a child, stigma from family and communities, and still the academic pressure. And there is a multi-country study called INSPIRE study currently being conducted in Kenya and Mozambique that is looking at co-designing mental health intervention to support teen mothers returning to school. And they've demonstrated higher proportions of anxiety and depression among them. And they've built an intervention that includes psychosocial counseling to support them so that they can still play their adolescent being. They can still be adolescent at school when they've left the children's at home, and also identifying the support system. So it's a specific population that our study currently cannot answer questions about that, but the population at high risk of mental illnesses, and that warrants an attention for them to be explored specifically. And about the 65%, so that was an odds ratio of 1.65 times for students in private schools as compared to those in government schools. So it was not a percentage. However, it still translates to the fact that those in private schools had higher odds of having anxiety. And looking at studies, this finding was consistent to other findings that pointed towards higher workload in private schooling students. And this is usually in attempts to uphold the school status, encourage enrollment. And speaking to that, students also mentioned that schools that would separate streams based on how you have performed, like maybe A graders will be stream A, B will be the other stream. They've mentioned that, and that has also been mentioned in several studies conducted in various settings. And also another thing that was mentioned that happens in private schools is the fact that if you do not attain a certain average at the end of the year, your parents have to move you to a different school. And that's a practice we see with our children. That also came up among the students as a source of constant worry and stress, especially when they're approaching exams. And other studies have also demonstrated the same. So we could further look into that, but those are eluded factors that could be explaining the observation in the quantitative study. For the age of inclusion, so we included students all ages 10 to 19 years inclusively, and majority were in secondary school, that was 62%. And looking at distribution of the participants in the age category of adolescent, we had 36% age between 10 to 13. So we had students across all the age span of adolescent 10 to 19 inclusively. And with regard to DES response being the lowest in our study, so DES was the longest tool that we had. It had 18 questions as compared to only 9 questions in GAD 7 and 7 question in GAD 7 and 9 in PHQ 9. And theirs originally was even much longer. The original DERS tool has 36 questions, and attempts to shorten it has been because of completeness and for participants to be able to fully respond to it. So those who did not complete DERS, we cannot argue against the fact that they could have been systematically different. They could have introduced the bias to a study. They could have been the one with higher emotional dysregulation that they just didn't, complete the tool. Hence, that was stated as the limitation of the study. And we attribute it to it being the longest tool in the study. And same observations have also been seen in other settings where they've used the similar tool. And on my last question was on ethical issues. So when conducting the studies, when all the focus group discussion of students was conducted at school environment, and the student responsible for the teacher responsible for, they're called counseling teachers or discipline teachers who are also responsible for mental health were informed. And in case there would have been an eruption, we are arranged to have to take care of the patient. One of the team members supporting the qualitative interviews was a social scientist and also worked with a counselor, but there was not any adverse event of eruption during the interview. Those who screened positive, however, after the analysis, we contacted the parents through the numbers that were recorded in the consent forms to inform them that your child screened positive. This is not to say they're sick, but it's a positive screen, and to encourage them to seek care in the nearby district health facilities.
Thank you. Gertrude, do we have William online? William?
Yes, I'm here.
Yes, we had a question on the role of regulators regarding these horticultural practices and pest.
Thank you very much for bringing this question up. We currently have pesticide regulators in the country, the TPHPA, the Tanzania Plant Health and Pesticide Authority. It's the authority that is responsible for registering and monitoring pesticide use in the country. However, that is under the agriculture sector. In the health sector, where we focus on the toxicology part, we don't have machinery for that. That's why we don't have people, health-related personnel in the agriculture, in the farms, who will be guiding these farmers on the safe handling and use of these pesticides. So first, we have the health sector need to have regulators within the agriculture sector, and second, that regulatory authority will have to assist the agriculture sector in filtering out pesticides which are known to have these hazardous effects, and in the long run, work with farmers in this aspect, women, in helping them safely handle pesticides so that they won't affect them or their children themselves. So the answer to that question is yes, but not on the health part, not on the health sector. Thank you. So it will continue to be business as usual for some time until these pesticide death effects become recognized in the country and regulatory authority specific to that is designed. Thank you.
Asante, Dr. William. Thank you for our panelists, our presenters. Thank you, William, online. Can we have pasha kubwa tatu kwa presenters? Start. Hizo kubwa kweli. Haya. Asanteni. So we have lunch served, but we also have to go for the poster viewing and booth visit. Karibuni.
Okay, sawa, asante. Ameshatangazia au mwambie tangazi. Mwambie coordinator huyo.
Please don't scroll. Listen to me. My name is Hiba from Gaza, and I'm supposed to be studying for my medical school final exams these days. Sorry.
Hello. Tunaomba tuelekee kwenye poster viewing. Chakula kinaandaliwa bado kinanukia nukia. So we go to poster viewing and booth visits, and then we'll proceed for lunch. Asante.
Tunafanyaje share? Stop kwanza uliwazo. Good afternoon, ladies and gentlemen. Nimesahau kusema mimi ni senior resident. Naomba nianze. I'm a senior resident. Sisogei, ngoja tafuteni. Sasa, itabidi niende naangalia huko. Umepata nzuri? Yani. Haya. Cha ukweli, haya. Simama kwa huku pigana. Kaka vizuri. Basi basi. Kwani pia basi. Haya, ngoja nifanye hivi.
Ah, kumbe natumia hii hapa. Ah, umeona eh? Naonekana kweli.
I would. Dad. Are you a procurement specialist looking for a new client, job opportunity?
Next time.
Shida hiyo. Balance haiko nzuri. Wamekosea. Exactly. Kosea. Sasa kidogo. Hello. There's a music going on. Can you switch it off? Hello. Can you hear me? Good afternoon, everyone. So we are going to start our session. And I would like to welcome you into this exciting, which will be on health living and health aging. So my name is Dr. Omari Chilo, and I'm so proud that I'm going to chair these sessions. And we are going to have prominent who are also very key personnel in this health sector. They are going to give to us a fresh perspectives on the physical activities, which comprises of our daily activities as well. Our speaker today is, we have 3 speakers. We have Dr. Frederick Mashili, and I'm going to read his bio when he was coming to present. We also have Dr. Omari Buguyu from the Ministry of Health. And then we have our legend in physical activity. We have Abdallah King Kibaden, who was a Simba player back then, years back. But also we have Dr. Waziri Ndonde, who is our physical fitness trainer and also is going to open the gym for this evening. So let us start to have our first presentation from Dr. Mashiri, who is going to speak about the physical activity and in relation to healthcare. Karibu sana, Dr. Mashiri. Sorry, Dr. Obuguyu. So Dr. Bugul is Assistant Director of Health and Non-Communicable Diseases. He's also a mental health expert on injuries as well at the Ministry of Health in Tanzania. He has over 15 years of experience in administration, the clinical work, research, as well as training. And he played a vital role in developing and implementing the Tanzania Physical Activity Guidelines, as well as action plans. He is a PhD candidate at MUHAS in collaboration with the University of Copenhagen, and he's going to specialize in behavioral sciences and health system strengthening. Dr. Obuguyu is a certified global trainer under the International Center for Credentialing and Education for Addictive Professionals. He also led national initiatives on physical activity and health diets, but also coordinating efforts with the WHO, as well as the International Olympic Committee and the Tanzania Olympic Committee as well. He has extensive work, which include over 30 publications on adolescent mental health, addiction, NCD, and health system strengthening. Dr. Bugulu led the comprehensive analysis of enablers and barriers to physical activity promotion in Tanzania, which leads to the development of Tanzania physical guidelines as well as the action plan. Karibu sana. Please.
Habari za mchana jamani. I'll just take you through the physical activity situation analysis report and our action plan, because sehemu kubwa ya our action plan imezaliwa kutoka katika assessment report. So we were responding to the gaps observed from the physical activities analysis, which were conducted 2 years ago, 2 or 3 years ago, and then miaka miwili iliyopita we were able to develop the action plan. Now I'll just stick on that component of action plan because issue related to aging and the benefits of physical activities during aging, I think Dr. Mashiri will speak more about that because there is issue related to physical activities physiology and related components. Kabla hatujazungumzia kwa sababu we hooked it with NCDs, so probably tungekuwa tuna picture in a nutshell NCD ni tatizo kubwa kiasi gani katika taifa letu. So looking at the statistics, especially looking at the country profile, we have observed kwamba NCD now is among the leading cause of mortality in Tanzania. On the top 10 causes of mortality, ukiondoa upper respiratory tract infection, plus some of the febrile condition, malaria na related component. Nafikiri a fourth one ni cardiovascular condition. Eighth or ninth ni diabetes. Yeah, kuna condition kama tatu za non-communicable diseases naingia among top 10. Na first 5 cause of mortality in Tanzania ambazo sio non-communicable, they mainly occur kwa under 5s. Kwa ukizungumzia hapa respiratory tract infection, kizungumzia nini, most of these zinatokea kwa under 5. So among adults 30 years plus, I think number 1 cause of mortality ni non-communicable diseases, lakini kwa sababu wengi wanakufa wakiwa watoto, then the spectrum ina bulge zaidi katika infectious condition, especially kwa under 5. So looking at our country profile, 34% cause of mortality in Tanzania, they are due to non-communicable diseases. Cardiovascular conditions lead with 13%, and the least cause of mortality among NCDs, diabetes and cancer, which attributed to only 2% of that. Now, as a country, progress toward key important parameters, especially kwenye non-communicable diseases, as far as SDGs is concerned, health iko katika Sustainable Development Goal number 3. Now, with that, there are 3 key goals. 3.4 ambayo inazungumzia reduction in premature mortality caused by NCDs and reduction in mortality caused by suicide. So 2 components za NCD zinazungumzwa hapo. La pili, 3.5 tunatazama reduction in use of substances, especially alcohol. As a country, we are not doing well katika alcohol, per capita alcohol consumption. As a country, tuna consume 10 liters of alcohol, pure alcohol, per year per person. We are the 3rd leading country in Africa after Uganda, after Mauritius and Uganda. Sisi ni namba 3, Afrika nzima tumechukua kombe wa 3. And then tunaangalia katika mortality caused by injuries. Na hapo tunazungumzia road traffic accidents. So mortality caused by injuries ni key component tunapoangalia SDG na how are we going to reach on sustainable development goals. So hii ni global picture ya kuona NCD inafanya vipi nchini, kwa sababu physical activities is one of the key components katika reduction ya non-communicable diseases. Kuna other risk factors ikiwemo alcohol, ikiwemo healthy diet as a key component. The last one is use of tobacco. Na mental health and stress zinaingia kama additional component ya 5x5, wakati environmental risk factors tuna add as one of the key risk factors kwenye NCDs. Sasa our talk today ina concentrate kwenye only one risk factors, which is physical activities. Mashiri kama mtaalamu ataizungumza vizuri zaidi. So when we talk of physical activities, hatuangalii tu watu wamekimbia asubuhi au wamefanya nini katika mazoezi. Mazoezi unaangalia kama ecosystem, yana key component, 4 major areas of physical activities lazima uwe navyo. Lazima tuangalie society. Kama tunafanya mazoezi alafu wanafanya mashiri peke yake MUHAS nzima, bado mazoezi katika community ya MUHAS hajapata kipaumbele au picha taswira inayotakiwa. We look at MUHAS as a society. Kwa hiyo even a country tunaangalia as a society. So society is one of the key components. Key component ya pili ni environment. Lazima to create enabling environment ili watu waweze kufanya physical activities. Kama there is no enabling environment, then mazoezi pia ni riski. Ukifanya mazoezi alafu kuna kugongwa na gari, it's better if na non-communicable disease when I'm 60s kuliko nikifa kwa kugongwa na gari wakati niko na 30 years. Kama na trade, sina sababu ya kufanya mazoezi katika mazingira ambayo ni hatarishi. So environment is one of the key components katika ecosystem. Tunazungumzia people, tunazungumzia society in general, but kuna watu, we need champions, we need vitu ambavyo vina stimulate watu kama motivators kwa individuals, and then we need a system, very supportive system. Coordination activities zinafanyikaje, resources tunapata wapi, tuna monitor vipi. So those are the 4 key components. So kabla tujaangalia kama nchi tunatengeneza vipi action plan, so we had a chance to look on those 4 key parameters. So wakati tuna observe kwenye active environment, I mean active society, kama country, kabla ya mwezi wa 5 mwaka huu, tulikuwa tuna kampeni moja kubwa kuliko zote, afya yangu mtaji wangu. Mheshimiwa Rais wa Jamhuri ya Muungano wakati yuko makamu wa rais 2016 alizindua kampeni ile ambayo tunajua Jumamosi ya pili ya kila mwezi lazima tufanye mazoezi, si ndio? That was a campaign from makamu wa rais, na ndio ilikuwa kampeni pekee tukafanya mwaka mzima 2016. Alafu 2017 watu wakasahau, 18 ikapungua. Wakati tuko 2019 walikuwa wanafanya watu, lakini kidogo kidogo, sio katika pace kama ile. This time tumeongeza number of campaigns kusupport hilo, lakini as you know religions, cycling, uendeshaji wa baisikeli, kufanya zoezi interventions ambazo zimekuwa proposed na some Mashiri atazizungumzia kwa sababu ndizo zitakuja kuwa bolded. I'm just paving a way for Mashiri kuelezea vizuri zaidi how best tumejipanga katika hilo. So moja, kwenye campaign kwa kiwango kikubwa, afya yangu mtaji wangu bado inasisitizwa. Jumamosi ya pili ya kila mwezi tufanye mazoezi. That is very key. Ya pili, matumizi ya public open space imepungua. Mimi wakati niko mdogo nilikuwa born and raised wireless. Kwa hiyo maisha yangu kwa sehemu kubwa sana wireless, nyuma tu ya uwanja Taifa. Kulikuwa hamna kulipia kiwanja, hakuna kutafuta uwanja. Mkitoka tu popote pale kuna viwanja, yani open space zilikuwa zaidi ya 20. Na almost all primary and secondary schools kulikuwa kuna viwanja vya kucheza kwa kadri unavyotaka. Ukiwa nakaa wireless, unaposhuka uwanja Taifa, chuo cha Chang'ombe ambacho ni Duse sasa hivi, kile kilikuwa na professionals, viwanja kwa ajili ya michezo ya basket, mazoezi ya kila aina yalikuwepo, na hakuna uzio, hakuna mlinzi, yani ni wewe tu wakati gani unataka kucheza. Kwa hiyo kama saa 10 wanacheza watu wazima, saa 7 kamili jua kali watu wazima wacheze, watoto wanacheza. So it was so easy kuona hizo open space kwa ajili ya watu kuchezea. Sasa hivi you can't, huwezi kupata access ya hivyo. Kwa hiyo the only plan ni kuhakikisha kwamba serikali inatenga and ina protect. Sasa hivi vikao vya kijiji vikikaa vinaamua open space iwe soko, kwa sababu ile iliyoacha wazi haizalishi. Mnakubaliana, mnapiga kura, mnabadilisha inakuwa soko. So those are the areas ambazo zilikuwa zina weakness. Na hili la trainers, hakuna, watu wengi wanaanguka kwa sababu there are no trainers. Watu wanaamka tu asubuhi wanakimbia. Eneo la pili which is very key ambalo tuliassess ni kutazama kwenye active environment. Nimesema mwanzo kwenye road traffic accident Tanzania na data za Dar es Salaam zinaonyesha kuna rate ya 36 death katika kila accident 100,000. Katika population ya watu 100,000 wamepata ajali, 36 mortalities zinatokea. Ni highest rate ukilinganisha na Africa as an average, kwa sababu Africa ni 26 na global ni 17. Kwa hiyo it is not safe kwa maana ya matumizi ya barabara. Ni topic ndefu sana katika masuala ya road safety, na maeneo mengi hayana zebra crossing, na iliyokuwa na zebra crossing watu waheshimu. Hakuna walkways na hakuna sheria ambazo zinamzuia mtu asipite kwenye walkways, hata kama zingekuwepo. Bodaboda, bajaji pia zingepita. Kwa hiyo ajali ni kubwa, lakini pia uwezo wetu wa kurespond wakati wa ajali pia uko chini. Mambo mengine ambayo we observed, viwanja vipo. Jana tu jioni nilikuwa pale Aura Mall. Ukikaa 16th floor, unaangalia chini upande wa kuelekea DIT, kuna kiwanja pale cha Asas. Nyuma ya mahakama ya gereza la watoto, kuna Jamati, alafu hapa DIT. Pana viwanja pale vya Asas. Ukienda Mikocheni vipo, ukienda Muhimbili, pembeni hapa Skauti, vipo viwanja kama ile picha namba 1. Lakini watu wanalipia. Na unapewa just 30 to 60 minutes. Na vinalipiwa vile kwa saa. Na watu wanachanga 100,000, 1,500,000 ili uweze kufanya mazoezi. Viko vizuri kwa sababu wanafanya usiku. Jana nafikiri kama saa 2 usiku nilikuwa pale Aura, na kulikuwa kuna watu chini pale wanacheza. Lakini wengi ni Asians na sisi watu wa middle class and hapa. Kwa hiyo wale wenzetu wa mtaani ambao sisi zamani tulikuwa tuna freedom ya kucheza popote, wako condemned, hawana uhuru wa kucheza kwa sababu viwanja hivi ni vya kulipia. Public transport ni miongoni mwa vitu ambavyo vina promote physical activities. Kwa mfano, tungekuwa tunapanda mwendo kasi hapa tulipo, tungelazimika wote kwenda kwenye kituo cha mwendo kasi. At least 2 kilometers tungekuwa tumewalk, na unaposhuka unafika nyumbani kwako. Lakini kwetu sisi sasa hivi public transport haijawa promoted kiasi cha kutosha. Lakini pia hata ukitamani kupanda mwendo kasi kwenye ile kugombea, Profesa Sunguya, utashindwa kuongoza chuo. Maana kuna mtoto wa mtu unaweza kawa umembana wakati unagombania naye gari, kesho akashindwa kuingia kwenye kipindi. Kumbe mwalimu uligombania naye gari ukamwangusha, ukujua. Kwa hiyo kama public transport access yake inakuwa ngumu, tuna withdraw watu wenye classes za juu. Kwa hiyo hilo nalo lilikuwa ni sehemu ya msingi. Lakini ukienda maeneo mengi kama Kariakoo and the rest, watu wanapanga mitumba, wanauza biashara barabarani. Kwa hiyo wanalazimisha watu watembee zaidi ndani ya barabara kuliko maeneo ambayo yako allocated. Kwa hiyo those were the gaps, na our action plan tried to address that. Na mtakumbuka mwezi wa 5 tulizungumza kampeni ya Car Free Day. Mheshimiwa Waziri Mkuu alizindua barabara ile inaelekea Tanzanite bridge iachwe kila Jumamosi ili watu waweze kufanya mazoezi. Lengo ni kupromote, moja ni kama sehemu ya promotion katika active society, lakini ya pili katika kutengeneza self environment kwa ajili ya kufanya physical activities. Tumejaribu kuangalia our people, are we active or not? Ukitazama kwenye step survey, Africa is one of the active continents. More than 80% of Africans are active. Tanzania, to rate almost 93% ya Tanzanians are active as far as step survey is concerned. Only 7% of Tanzanians are inactive. So even our subject matter unaweza kaiona kama ni irrelevant kwa sababu kama tuko 97%, what else do we want? Lakini ukiangalia kwa upande wa pili, especially kwenye population ya adolescent 14 to 17 years of age, wakati tunafanya global school based health survey, 20% ya watoto wetu wameripoti kuwa na sedentary behavior and only 27% ndio wana meet requirements. Kwa hiyo na wengi mtakuwa mashuhuda hapa, tukitazama watoto wetu they are less active kuliko sisi wakati tuna umri ule, na kwenye physical activities our standards is different from theirs. Wanahitaji kuwa more active kuliko sisi, moja kwa sababu ya motor skills, lakini ya pili ni kwa ajili ya train ya kawaida kwa ajili ya zile gains za physical activities. So na analysis ya ile 97% ya watu ambao sasa wako physically active ambao walikuwa wanafanya mazoezi because of leisure au kwa ajili ya afya zao, so either kwenye leisure physical activities or reason was health, it was only 6%. The rest walikuwa forced in circumstances, kwamba nafanya mazoezi how, anasema mimi bwana huwa nasukuma mkokoteni, mimi kazini kwangu huwa nabeba mafaili, mimi huwa nalima. Kwa hiyo tuna count kwa sababu ule muda kweli iko physically active and that somebody can gain impact ni ile ile, kwa sababu ukiwa uko active kwa sababu unalima ni sawa sawa na anaamua kukimbia. Ukiwa active kwa sababu unabeba ndoo za maji ndio kazi yako, ni similar na mtu ambaye anaenda gym, hamna tofauti kwa maana ya impact. Lakini in leisure physical activity tunaamini kwamba this is a behavior, and if it is a behavior itakaa muda mrefu zaidi na ni voluntary. Kama ni kwa sababu wewe ni mkulima, ukibadilisha ukipelekwa kwenye pawatila, maanake definitely jembe utaacha na and then you won't be active anymore. Na we observe that unapokuwa na mtu ametoka, alikuwa afisa wa kawaida, sasa hivi mkurugenzi, sasa hivi ni DVC, anaacha, anakuwa na kitambi kwa sababu yuko kwenye gari inafuata asubuhi mlangoni, inamfikisha ofisini, ndio hivyo anahama sasa kutoka kwenye daladala, kitambi kina set in. Kwa hiyo physical activities that we want to promote ni leisure physical activity, na haimaanishi tu kukimbia. Hata kama ungekuwa unacheza ngoma, unafanya nini, those are the kind of things that we promote, but unfortunately kwa Tanzania is only 6%, and that is the one ambao tunaitarget katika physical activity action plan. Hizi zingine tunafurahia na tuna promote ziendelee. Workplace physical activities ni muhimu, lakini leisure is very important. Na we have 3 strategic interventions ambazo zinatazama hapo. Kwenye workplace tulijaribu kufanya assessment last year kuona kama response ipo. Tumeona 70% bado they are inactive in workplace. Kwa hiyo bado hatujafanya vizuri sana. Then kwenye system tuliona tulikuwa tuna 14 policies ambazo hazija align. Yani afya, even Public Health Act ya kwetu wenyewe ya afya haija address physical activity. Of course it was Public Health Act ya 90s ya 80s, na issue kubwa zilikuwa kipindupindu. Kwa hiyo ukiisoma sheria ya afya ya jamii inazungumza mambo mengi sana ya migonjwa mlipuko and issue related to that. Haizungumzii hata nutrition kwa kiwango kikubwa, haizungumzii physical activities. Ukiangalia policy ya michezo yenyewe haipromoti, inazungumzia Simba na Yanga, inazungumzia soka zaidi kuliko physical activity in general. Kwa hiyo tulikuwa tuna 14 policies hazija align, hazipromote physical activities. So tumetengeneza timu ambayo sasa tuna technical working group, ni interministerial kwa maana ya multisectoral, lakini tuna hii action plan ambayo tuita wote pamoja, lakini tunahitaji kuwa na more evidences. Most of these evidences that we are giving hazirely na what is happening in Tanzania. Kwa hiyo tunashukuru MUHAS, nafikiri Mashiri pia ataizungumzia, namna ambavyo generation of evidences MUHAS inatusaidia, na kuna mambo mengi ambayo tutafanya nao pamoja. Tunaishi ngumu sana hapa resource mobilization ambayo si nyepesi. Sasa what are the costs of inaction? Tusipofanya physical activities, tusipodili na NCD, what are the costs? Ziko nyingi. Tuna obesity. Hata step survey mpya majibu hayajatoka rasmi, na naogopa kutajataja mara nyingi na kuga na kimbelembele, lakini obesity haiendi chini, bado obesity inaenda juu, na vitu vichache sana katika obesity: namna tunavyokula, namna ambavyo tunatumia chakula tulichokula, kwa maana tuko active kiasi gani. Kwa hiyo moja ni hilo, ongezeko la obesity, na obesity ni mama wa metabolic syndrome na any other disorders ambazo zinafuatana na hiyo. Lakini studies nyingi zinaonyesha kwamba globally 2014 when they analyze risk attributed na physical inactivity, actually 54 billions USD zinatumika per year, direct or indirect, ku address issues za non-communicable diseases related to physical inactivity or sedentary behavior, ambayo ndio major issues. Vingine vyote vile ambavyo tunavizungumzia, obesity, tunazungumzia hizo metabolic symptoms ambazo tunaziona, mortality na morbidity related to NCDs, ziko kwa kiwango kikubwa sana attributed na physical inactivities. Na ukiangalia in general disability adjusted life years inatokana na NCDs ina attribute 41% ya kila kitu. Namaliza, naona mashine unaniangalia, natakiwa kutoka. Uzuri ni kwamba future is promising. We are very lucky kama nchi. Tumekuwa na marais 5 katika nchi hii. All of them wana promote physical activities. Rais pekee ambaye hakuwahi kusema neno mazoezi akalirudia mara nyingi, Mkapa. Sikumuona akizungumza, na mpirani hata hakwenda, mara chache sana. Magufuli pia kuizungumza neno mazoezi mara nyingi, lakini push-up zake zimetu remind several times kwamba kuna mazoezi, na that was very iconic. Wakati anafanya kampeni muda wote iko kwenye mazoezi. Kwa hiyo sisi tunaamini with them kama role models ni rahisi, kwa sababu promotion namba 1 inatokea kwa watu who matters katika physical activities. Na ndio maana hata katika session yetu leo tuna mzee Kibaden, Abdalla Kibaden, yeye atakuja kusimuliwa sifa zake hapa. Ni mchezaji king, yani katika soka ni mfalme, ana maana kubwa sana. Kwa hiyo kwa kuona role models katika level ya Mheshimiwa Rais, it is very easy kuifanya physical activity move forward. Na actually it is an agenda, kwa sababu agenda which is anchored higher in the offices. Rais amepromote physical activity several times, anakuwa akizungumza kila wakati. Na alipofariki Mheshimiwa Rais Mwinyi, katika sentensi ambazo alikumbukwa nazo, ambazo maneno kutoka kwa rais ni tunamkumbuka kwa sababu ya mazoezi yake, amemfanya aishi muda mrefu kwa sababu ya mazoezi. Mazoezi yanakuwa attributed na vitu vingi sana katika non-communicable diseases. Nafikiri wakati wa kuchangia nimemwona Profesa Kaaya anaweza kutusaidia, akatuambia how mazoezi yanaweza kutusaidia katika mental health kwa kiwango kikubwa sana. Neurotransmitters nyingi ziko stimulated wakati wa mazoezi, na norepinephrine na ndugu zake serotonin, neurotransmitters zinazalishwa kwa kiwango kikubwa mno. Wakati mwingi baada ya mazoezi unajifeel happy, ni kwa sababu ya hizi neurotransmitters ambazo zinazalishwa. Na tumezungumza best mode kama unapata shida ya sleep disturbances, sio kunywa pombe. Ukinywa pombe ni kweli utafumba macho, sio utalala, utafumba macho kwa sababu utakuwa sedated kama uko kwenye anesthesia ya kawaida, lakini hutokwenda na zile sleep cycles ambazo ni rhythmical, ziko regulated, zina biology yake, zina physiology yake. Ni physiology inayojitosheleza. Ukinywa pombe unajisedate, na kwa hiyo hutoenda katika biology ya kawaida. Ukifanya physical activities utalala na rhythms zitakuwa za kawaida. Kina REM sleep utazipata na non REM sleep zitakuwa prolonged na zitaenda vizuri zaidi. Kwa hiyo ni dawa pia ya usingizi. Sijui Kibada anakuja kutuambia nini, dawa ya uzazi, so many things related to physical activities. Kwa hiyo kwenye wakati wa corona tuliwaambia watu wakimbie, ina so many other factors related to it. Labda mimi nipishe next speakers kwa ajili ya kuelaborate zaidi. Asanteni kwa kunisikiliza.
Another round of applause, please, to Dr. Obuguyu. Thank you so much, Dr. Obuguyu, for your presentations touching on the physical activity gap analysis, as well as the national plans and the future. Our next speaker is Dr. Frederick Mashiri, who is going to talk about promoting physical activities and its implementation of physical activity plans. So Dr. Mashiri is a senior lecturer and a chair in the Department of Physiology, Muhimbili. He has a medical degree from MUHAS, from University of Dar es Salaam, and a PhD from the Karolinska Institute in Sweden. He specializes in applying exercise physiology to prevent cardiovascular diseases. And he's a key figure in the WHO Trans Fat Elimination Technical Advisory Group and a member of IDLO Academic Working Group. He has contributed massively on the global cardiovascular health initiatives. Mashiri is also, Dr. Mashiri's comprehensive analysis of physical activity promotion in Tanzania. He has led him to the development of national physical activity guidelines as well as action plans. And he's continued to bridge the gap between the academia and the practical implementation of in advancing public health in Tanzania. So let me welcome Dr. Mashiri for the next presentation, please.
Thank you, Dr. Chilo. Let me just pull my slides. Good afternoon, everyone. So it's an honor to speak in front of you today as we are actually honoring the life of a physical activity champion by implementing Tanzania Physical Activity Action Plan, which has a long history from its development. And now we are realizing the implementation. And this really good day, we are honoring the life of a champion who led an active lifestyle to, I think, around 99 years. What I'm going to talk to you today is actually the role of academia in implementing the Tanzania Physical Activity Action Plan. And what I'm going to talk is how are we going to link health professionals and other implementers of physical activity, and basically the role of research and training. So Dr. Obuguyu has talked a lot about NCDs, and I believe in this conference it has been mentioned several times. But we know very well that the rising prevalence of NCD is very much linked to the rising prevalence of physical inactivity and sedentary behavior. And if you look at the left, the figure here, probably it's not very clear, but when we analyzed physical activity data from the 2012 STEP survey, there was a very clear relationship between a number of cardiovascular risk factors and low levels of physical activity. So what you can see here is when the levels of physical activity increases, some of these risk factors are taken care of, so they decrease. Now, one of the things that we always talk about is the benefit of physical activity. which are very well known. But I like to talk about the ones that everyone would like to hear, or some of the things that are not talked much, especially when we talk about resistance training, which is usually neglected. A lot of people think about aerobic training, and I like to advocate resistance training. And one of the benefits of resistance training, but also other form of physical activity, is to increase levels of endorphins and testosterone. The reason why I like these hormones, because these are actually hormones that will make you happy. They will motivate you. They will increase your performance. These are the ones that will make you feel good when you wake up in the morning. So when you regularly participate in physical activity, your levels of endorphins, but other hormones, testosterone, which is a performance hormone, increases. You should remember that testosterone is a male hormone, but even women have testosterone, and the levels of testosterone is also important in women. But the other thing which was very much realized during COVID time is exercise has an obvious effect on the immune system. So regular physical activity contributes or acts as immunobooster. And we know very well that people who were active, either they were not getting severe form of COVID or they were not dying from the disease when they get it. And those who were leading a sedentary lifestyle, we know exactly what happened. But very well, it is known, and Dr. Buguya has talked about it, prevention of diseases being the main reason that we are talking about physical activity, but also control of diseases. If somebody already has hypertension or diabetes, participating in regular physical activity can control the blood sugar, can control the blood pressure, but also vitality and longevity, which is the story of today. So if you want to lead a vital life and you want to live longer, obviously, if you participate in regular physical activity, that is going to be true. And it is very well established that people who are participating in physical activity are 10 years younger than their chronological age counterparts. So this is obvious and evidence is overwhelming. Now, talking of the National Physical Activity Action Plan, as I said, it has a very long history from 2015, when some of the activities started to develop a roadmap which is going to guide the promotion of physical activity in the country. And obviously, the ultimate goal of this is to bring stakeholders who are playing part in promoting physical activity in Tanzania. And currently, we have the action plan, but we also have the physical activity action plan. And the MUHAS participated in all the steps and stages in developing this National Physical Activity Action Plan. Now, when you talk about physical activity or when you talk about the burden of NCD, most of the time, the blame is on the health system. But the reality, when you think about the risk factors, there are so many players who are actually responsible to making or contributing in some of these health promoting behaviors. And when we talk about physical activity, everyone will agree with me that nowadays there are a lot of people who go to the gym for physical activity, and we have fitness trainers. And from the analysis that we did, most of these physical, fitness trainers are not well trained. So we are going to talk about some of the strategies that the academia can contribute in actually training these fitness trainers, because they're also dealing with patients. But we also have urban planners. Dr. Bugu talked about the roads, the way the cities are planned. So the urban planners are also some of the people who can contribute in making people active. But nowadays we have wellness, which is also a growing industry. The schools can also be activity promoting areas. And at the end of the day, the policy, because we need to have the system. And at the end of the day, what we need to have is to bridge these different stakeholders. And there's a role of research and training in actually linking health professionals to other physical activity players for the effective implementation of the Tanzania Physical Activity Action Plan. Now, Dr. Buguya has talked about the strategic objectives within the action plan. The first one being to create an active society. And here we are talking about the campaigns, the events that we have, but of course, something that the academia can play, which I'm going to talk about it. The second one is to create the active environment, enabling environment, meaning the policies, but also the infrastructure, safe roads where people can cycle, they can walk, but also having policies that are guiding that. And the third one is to create active people who are motivated to participate in physical activity. And the last one is to have the system in place. Now, part of the creating the active society, the strategic intervention number 3 of the Tanzania Physical Activity Action Plan, what is envisioned is to strengthen pre and post-service training of professionals within and outside the health sector. Now, talking of pre-service training, one of the things that have been done right now, which is part of the revision of the curriculum that is ongoing at MUHAS, we had a MSc program in physiology. We've tried to include exercise physiology within that program so that we can create a cadre that can actually deal with physical activity. So we create professionals who are well-trained in dealing with physical activity. So this is one of the intervention, one of the contribution that academia is doing in implementing the Tanzania Physical Activity Action Plan. But the other thing, we have doctors. And as doctors, we know how to prescribe drugs, but probably we don't know how to prescribe physical activity. One of the things that is quite common in clinics, you know, a doctor will tell a patient, kafanya mazoezi, but they won't say what type of exercise, how, when, and what is the dosage. And this is something which we really need to intervene. And one of the things that has been done and what is expected, a doctor should tell a patient or a client the type of exercise, but also the intensity of exercise, the duration of exercise, and so many other things. Now, to be able to have this knowledge, some kind of training is supposed to be there. But the other thing, nowadays we are talking of precision medicine. Precision medicine means individuals are not the same. And with technology, we have tools that can assess. And then you get a health profile or a fitness profile of an individual. And based on that, one can prescribe the right exercise tailored to that particular individual. So these are some of the things that we are actually doing. And we are moving to the era of exercise prescription, whereby exercise prescription is written as a prescription when you're writing medicine. And one of the things that we are going to do is to review and update our pre-service, but also post-service curriculum, and then to develop and implement post-service short courses, which are going to train healthcare professionals to be able to prescribe exercise. And we have short courses that we've already developed. Of course, they are coming soon. One of them being weight loss short course for health and wellness and fitness professionals. So we have this short course, which is coming soon. And we have another short course called exercise and physical activity prescription for health professionals, whereby doctors, nurses, anyone working in the health sector will be able to prescribe exercise to clients, but also patients. Now, as I've said, we have many non-health players who are also contributing to the implementation of the physical activity action plan, and there should be a bridge. We are moving to an era whereby a doctor can write a physical activity prescription and the gym trainer can dispense. It's like pharmacy dispensing. So there should be a crosstalk between healthcare professionals whereby you write a prescription, and then when somebody goes to a gym, a fitness trainer can read that prescription and then work with that patient to give the right and appropriate type of exercise. So training is really crucial here, whereby we need to have this ability, a crosstalk between healthcare professionals and other implementers. And one of the courses that we have developed, of course, it is also coming soon, is basic course for fitness trainers, because we know that gyms are like hospitals nowadays. They're people who are sick who are going to the gym. So the fitness trainer need to have the ABCs of diseases, things like blood pressure, and they need to have ability to do basic assessment so that they don't cause harm when trying to work with those patients. So there's a course, a short course that we've developed, which is a basic course for fitness trainers. So when you go to a gym, you don't have to worry about the trainers that you're going to meet in the gym. But then strategic intervention 3 also talk about strengthening pre-service training by conducting training sessions to primary school teachers, because we know that teachers are working with pupils, and they need to be able to teach them the importance or the health benefit of physical activity, not just physical activity as sports, but rather what we call health enhancing physical activity. So we also need to do training with the school, primary school teachers, so they are able to link physical activity and health and teach the pupils. And then on the active people, we have to develop and disseminate protocols for patient assessment and brief advice on physical activity for primary healthcare settings. So we need to have a guideline. So the point here is we need to have a protocol whereby physical activity assessment can be done, be it in a hospital or anywhere, and then the right prescription can be given. And one of the tools that we already have, there's a book called Mtindo wa Maisha. This is quite general. So we need to work on this and develop a pilot, a national guideline, and then pilot that guideline in a few healthcare settings. So these are some of the things that academia can actually contribute in the implementation of the physical activity action plan. So the other thing which we are going to kind of launch today, a program which is called Wellness Weekends with MUHAS, which we call it Wewe na MUHAS. And this is a program whereby you can have health and fitness profile assessment so that you can actually know the profile of a person. And based on that, exercise or physical activity can be prescribed. As I said, this is based on individual and based on the assessment. And then you can also have nutritional and diet prescription based on the assessment, which will be done. And then you can also have supervised exercise session. And this is going to be monthly. So after this session, we are going to tour the gym, which is downstairs. So you're going to see some of the equipment that we have, but also assessment tools that we have. And this is part of the academia contributing to implementing the Tanzania Physical Activity Action Plan. And then you can have progress monitoring. So if you come to the gym, we do an assessment, we give you a prescription, and then you go back home, you do your exercise or physical activity daily. After a month, you come for progress monitoring to see whether you have improved or not. If there is any kind of adjustment which has to be done, it has to be based on the assessment and not just blindly. So this is a program which will start at MUHAS here at this campus, whereby we will be doing these assessments monthly, and it's going to be the second Saturday of every month, where we'll be doing this, where we'll also have supervised exercise, where you have a trainer who can teach you how to do the right type of exercises. And at the end, we have the active system, which I think Dr. Buguyu talked a lot about this, that at the end of the day, we need to have a system in place. But part of this is evidence-based. And one of the things that we realized, we really don't have local evidence at all when it comes to physical activity. There's a very little local evidence. One of the work that we did was analysis of STEP survey, which was a countrywide survey on physical activity. But currently we have a lot of programs going on. For instance, I have a PhD student in our department who is looking at the compliance and effectiveness of structured exercise prescription among pregnant women. Pregnant women is one of the group that we tend to think that they have to be sedentary, which is not true. And now we are trying to see if we start doing a physical activity prescription, what is going to be the compliance and what is going to be the effectiveness of this. So we have a PhD student who is working on this program, and we have other research that we are doing just to create evidence which can help in policy reforms, but also practice at the end of the day for the prevention of non-communicable diseases. So in a nutshell, what academia can do is to link health professionals, but also other implementers of physical activity. As I have said, we have fitness trainers, urban planners, wellness professionals, teachers, but also non-government organization and the government, because this is where the policy is coming from. Thank you very much.
Thank you so much, Dr. Mashiri, for your presentation. And I always look as an example to Dr. Mashiri, and he has inspired the other 3 members of our department to become, except myself. So I'm trying hard. So our last speaker is our legend, and his name is Alhaj King Kibaden. However, his real name, registered name, is Abdallah Thman Saif, who is here with us, and he's a known legend in football in Tanzania. He played for Simba for many years, as well as Majimaji of Songea. I hope if we will be playing by this time, Yanga would probably trying to snatch him to Yanga and leave Simba, but he was always with Simba for many years. And Kibaden, he was a fame in the football, and also he started football coaching as well in Germany, Mauritius, and Belgium. And in one time, he successfully becomes a coach for Simba Sports Club and other various teams after his retirement from playing football. And he is also known to lead Simba to CAF tournament finals in 1993. How many of you were born by 93? I think you are very few here. I remember this day. I cried a lot. You know, Simba lost by 2-0. But also Kibaden owns a Kibaden International Soccer Academy, which nurtures young football talents in Tanzania. And he has over 45 years experience football, but also he's still playing football, but also he's a regular physical activity champion for many years, and is now 74 years. So Kibaden, karibu sana na ukumbi ni wako. Please let us put our hands together. Kibaden atatuelezea kwa nini anaendelea kuwa yuko fit na miaka 74. 75, sorry, 75 jamani. Karibu sana.
Assalamu alaikum. Bwana Yesu asifiwe. Kwa jina kama alivyotamka kiongozi hapa, naitwa Alhaji Abdalla Kibadeni Mputa. Sasa haya majina yameongezeka kwa sababu ya umahiri niliokuwa nao kwenye soka, lakini baba yangu alinipa jina la Abdalla Athmani Saif. Sasa Kibadeni na Mputa yameongezeka kwa ajili ya soka. Kibadeni, nilipokuwa nasoma madras, wenzangu walikuwa wanaimba wimbo Abdalla Kibadeni kanyamavi mtendeni kasingizia wageni. Ni wimbo. Sasa likaingia jina la Kibadeni. Na jina la Mputa nimelipata nilipoenda Songea kufundisha. Nimekwenda Songea wakati nacheza, lakini sio kufundisha. Wakati nacheza nilikuwa nikichezea Simba, lakini mwaka 78 Majimaji walikuwa wanatafuta kocha na mchezaji. Kwa hiyo marehemu Mzee Gamba ambaye alikuwa mkuu wa mkoa alikuja Simba Dar es Salaam, akamuomba kocha wa Simba, alikuwa marehemu na Dimitar Samsov kutoka Bulgaria. Yule kocha akakubali kwenda Songea, lakini alimuomba Mzee Gamba anichukue na mimi
Mimi nilienda kama mchezaji, lakini alisema akimaliza ataniachia ukocha. Kwa hiyo nikaenda Songea, niliacha Simba. Simba wakati huo mabingwa, wanawakilisha nchi, na kuna wachezaji tuliokuwa nikicheza nao waliweza kutoka wengine kwenda nchi za Falme za Kiarabu kwa kuajiriwa kucheza mpira, lakini mimi nilikubali kuondoka kwenda Songea, sikukubali kwenda nje ya nchi. Na kilichonifanya kwamba marehemu babangu alikuwa kiongozi kwenye TANU, kwa hiyo hakutaka mtoto wake niondoke kuacha nchi yangu nikacheze mahali pengine. Kwa hiyo nikaenda Songea. Katika furaha ya watu wa Songea, mkoa wa Ruvuma, Mzee Gama akasema hawa ni mashujaa. Tulienda si peke yangu, tulienda wachezaji kama 3 4. Akasema hawa ni mashujaa, lazima tuwaingize katika familia ya Kingoni. Kilichofanywa, marehemu Gama alifanya sherehe, akaja na wenyewe wanaita kisonjo, kitu kikatiwa majina ya machifu waliokufa kwenye vita Majimaji. Katika majina ilibidi sisi wachezaji wageni kila mmoja akachukue jina moja, lakini sio kwa kutizama, kichukua kikaratasi, jina lilokuwemo ndilo utakalopewa. Sasa nilipokwenda kuchukua mimi, nikachukua jina la Mputa. Mputa ndio alikuwa kiongozi, ndio chifu wa Wangoni. Kwa hiyo Mzee Gama akasema hili jina ni kubwa, lazima tuwaambie watoto wake marehemu Mputa baba yao alikuwa anafanya nini, kama akitaka kuchukua mtu kumwingiza kwenye familia yake. Kwa hiyo uamuzi kawa lile nichukuliwe mimi niende Maposeni sherehe zilikofanyiwa, nikapewe jina la Kingoni la chief, nikapewa na mkuki na kitu kimoja, sikumbuki kitu gani, lakini kitu cha kuzuia kama una adui anataka kukushambulia. Kwa hiyo nikachukua vile vitu na jina nikaanza kulitumia jina nikabadilisha yale majina, sababu Abdalla Athmani Seif nikisema Abdalla. Kwenye mpira huku walinipa Kibadeni, nikaliweka la pili, alafu Mputa la 3. Nikaenda serikalini nikabadilisha majina. Kwa hiyo majina yangu kamili ni Abdalla Kibadeni Mputa. Kabila mimi Mzaramo. Kabila ni Mzaramo, nimezaliwa Mbagala Kiburugwa mwaka 1949. Ni mtoto wa pili katika watoto wa marehemu babangu Athmani Seif. Wa kwanza alikuwa kaka yangu, mimi wa pili, alafu kuna wengine wanafuata. Kwa hiyo kifamilia tumebakia 3, tulikuwa 6. Mimi wa kwanza, kuna mdogo wangu, alafu kuna na dada yetu mdogo wangu pia wa kike. Haya, upande wa pili, maisha yangu kikazi nilifanya nini? Nilibahatika kwenda shule, nimesoma darasa la 1 mpaka darasa la 8, wakati huo niko middle school. Nimemalizia shule middle school Makurumla hapa Dar es Salaam. Lakini marehemu baba alitaka anisaidie tena ikiwezekana niendelee kusoma. Nikamwambia baba, hapana. Kwani wakati nasoma nikicheza mpira barabarani narudi na hela nyumbani. Ile hela inatusaidia na baba kulipia hata hela ya shule ya ndugu zangu ambao nilikuwa nao. Kwa hiyo nilikuwa naanza kupata pesa kabla hata kazi sijaajiriwa. Sasa nikamwambia baba, nataka nisome niwe na elimu ya kutosha nipate ajira. Sasa simbona napata hela hizi, siwache niendelee huku kwenye mpira? Akasema haiwezekani. Ukitaka basi nitakupeleka mahali ukafanye kazi ujifunze. Kazi ya kwanza nilikwenda kujifunza kushona. Fundi cherehani anashona nguo. Akaona haitoshi, akanipeleka garage, nikajifunza motor vehicle mechanics. Na shahada na fundi sasa hivi wa magari. Lakini nikimaliza kote huko lazima niende kiwanjani nikacheze mpira. kule ninakocheza kuna watu walikuwa wananifuata kwenye makampuni. Kulikuwa na kampuni ya Bata Shoes wakitengeneza viatu, sasa hivi inaitwa Bora, nafikiri Bora Shoes. Kwa hiyo nikaenda kufanya kazi kule, lakini ikashindikana tena, bado watu wengine walinihitaji kwenye kufanya kazi. Nikenda nikapata kazi Tanzania Film Company. Kazi gani? Film technician. Zilikuwa zamani majumba ya sinema, kuna kampuni inapokea sinema alafu zinakwenda kuonyeshwa. Kwa hiyo ilikuwa kabla kwenda kuonyeshwa kwenye majumba ya sinema lazima zipitiwe kwamba kuna vitu ambavyo vingine vinakatwa havihusiki. Kwa hiyo nikafanya kazi hizo, lakini wakati huo nafanya kazi huku nacheza mpira. Sasa mwisho ajira kwenye mpira ikaja, nikaenda kuanzia kuchezea Majimaji nikiwa nikilipwa mshahara, lakini sio kwa kucheza mpira. Nilikuwa nalipwa mshahara kwa ajili ya kazi tu, nipate nini hii, kuendesha na mimi maisha yangu. Basi wakati huo ilikuwa tulipwe mishahara, kiwazo zawadi mnapata, lakini sio pesa. Kwa hiyo nikaenda nikachezea Majimaji, lakini akili nyingine kanijia. Wakati huo nacheza huku nafundisha, nilikuwa coach player. Kuna wakati kocha hayupo, mimi nafanya kazi ya kufundisha. Kwa hiyo nikawa naendelea na kazi hizo. Na lingine kubwa, nilipokuwa Majimaji, kwa heshima ya Wangoni wakasema huyu tumpe mke, lakini wakati huo nilikuwa na mke, lakini dini inaniruhusu mpaka 4. Kwa hiyo nikakubali, lakini wakaniambia nichague. Sasa Mungu naye mkubwa. Siku moja nimekaa ofisini kwangu, kina mama wawili wakaja wanaomba uwanja. Mimi ndio kwa meneja wa kiwanja, wanataka uwanja, wana sherehe zao. Haya, wewe mama nani? Kila mmoja akataja jina lake. Mmoja akasema yeye anaitwa Rehema Rashidi Kawawa. Kawawa ndio alikuwa makamu wa rais na waziri mkuu baadaye kabla. Sasa kama katika maswali akanambia ukitaka kunioa ruksa. Nikaenda kupeleka jibu kwa wale walioniambia nitafute mke. Nikaambia nimepata mke, lakini babake makamu wa rais mzee Rashidi Mfaume Kawawa. Sasa tutakwenda huko. Kwenda wakapeleka habari zangu, mzee Kawawa akasema mwenyewe akikubali waacheni. Kwa hiyo nikapata na mke, babake makamu wa kwanza rais. Mimi nilikuwa naheshimika barabarani, nikipita watu wasema mwacheni huyo bwana, babake mkwesi mnamjua. Kwa hiyo kasipati tabu njiani kote, wala anisumbui mtu. Kwa hiyo na mke wangu naye alikuwa msomi, tena alikuwa mwalimu, anafundisha sekondari. Kuna wakati alienda alitoka nje kwenda kufundisha Kiswahili, labda kwenda Gambia.
Mzee Kibadeni,
ndio
unakuja kwenye mazoezi sasa, maana mazoezi yakusaidia nini na mpira?
Kwa hiyo kwa hiyo nachotaka kusema kwamba mambo yangu hayakuwa na tabu kwa ajili ya mpira, ila nataka kujua tu kwamba nilitokea wapi. Kwa hiyo kikubwa, wale walimu waliokuwa wakinifundisha, kubwa zaidi wanasema kwanza kutunza afya yako. Huwezi kucheza mpira kama afya yako haiko sawa sawa. Kwa hiyo hilo ndio jambo la kwanza. Hata vijana hivi sasa ninavyowafundisha na academy yangu, watunze afya. Usikubali unakaa mbwa na kutafuna, usikubali kuchelewa kulala, usikae bila ya kula. Hivi vitu vyote ni muhimu kwa katika michezo, kwa afya. Lakini kwa hiyo nilikuwa nawaambia wajaribu kuepuka vitu vingi ambavyo vinaweza vikasababisha afya yao ikawa sio nzuri, wakashindwa kucheza mpira. Kwa hiyo hilo nataka kusisitiza kwamba hata wazazi tuwasimamie watoto, wakubali, wasikae tu hivi hivi, wapate nafasi muda wa kucheza. Mimi mwenyewe nilikuwa nakimbia hizi nguzo za hapa mjini za umeme, nguzo baada ya nguzo. Mimi nikikuta nguzo nakimbia mpaka nguzo, hata sio wakati wa mazoezi, hata nikienda na shughuli zangu tunaweza nikakimbia. Kwa hiyo kitu cha kwanza ni afya. Kama afya iko vizuri, usikubali tu magonjwa akakuingia. Hakikisha kwanza unakuwa safi, nalala mapema. Ni vitu ambavyo kijana binadamu hasa anatakiwa anavifuatilie. Kwa maana hiyo nataka kuambia ni kwamba huu mchezo wa mpira, hasa afya. Afya ikienda vizuri unafanya kila jambo. Mimi nimetamka na miaka 75, lakini naswali swala 5, nafunga Ramadhani, acha Ramadhani, sunna zote zinazotakiwa kufunga mimi nafunga kwa ajili ya kuweka afya vizuri. Ukiweka afya vizuri, Mungu anakusaidia. Nao watoto nimetaja, watoto wanafika 15, 16 wa kwangu. Na wote wapo, wana nguvu, wana shughuli zao. Na wajukuu wengine hata nikimwona hata jina silijui. Hata mtoto wangu kuna kipindi kifika unaweza ukamsahau, wewe nani, wewe ndo fulani, ndo namuuliza sasa wakati huu. Kwa hiyo afya nasema ni jambo la kwanza muhimu katika maisha. Alafu nyingine imenisaidia kwamba marehemu baba alikuwa kidogo mambo ya dini anaenda nayo vizuri. Hakubali mimi kipindi cha sala yeye awe peke yake. Kama sipo shule lazima tutakuwa pamoja. Kwa hiyo vitu vingi tunataka hawa vijana wetu, watoto wetu tuwasimamie kwa ajili ya kuweka afya. Mfano kwenye kucheza, hata unapocheza huwezi kucheza kama akili yako haiko sawa sawa. Una tatizo nyumbani, mpira utakukimbia, huwezi kucheza. Una tatizo kidogo, mimi nilikuwa nacheza, kocha akubali mimi niwe nje, ananipiga sindano ya ganzi pale panapouma ili mradi nicheze. Kwa hiyo afya nasema na sasa hivi bahati iliyokuwepo kwamba mpira ni ajira. Ule tulikuwa tukicheza sisi ulikuwa mpira watu wakutambue. Lakini mpira wa sasa hivi mtu anataka milioni 10, milioni 20 kwa mwezi. Sasa kwa nini watoto basi watu wasitunze afya zao ili mradi wakaweza kufanya kazi ya mchezo wa mpira?
Neno la mwisho kwa vijana na sisi natuambia nini kusema?
Neno kubwa ninalotaka kusema, watu wafanye ibada kwa imani kwanza ya dini zao. Wafanye ibada, watunze miili yao kwa kufanya mazoezi. Tena mazoezi sio mazoezi tu, natakiwa mazoezi yaliyokuwa sahihi. Kuna mazoezi mengine yanaumiza usipoelewa, au ukiazidisha kupita kiasi mtu utashindwa hata kufanya ile kazi unataka kufanya. Kwa hiyo watu wafanye mazoezi, tutunze afya zetu. Mwenyezi Mungu atatusaidia, tunaweza tukaishi maisha marefu kufuatana na afya zikiwa nzuri. Kufa kupo, lakini afya kwanza.
Shukran sana Mzee Kiba. Can I call Dr. Mashiri and Dr. Ubuguyu to respond some of the questions that will be raised from the audience? Mzee anasema mtoto 16. Nikajua mazoezi ni ya mpira au kuna mazoezi mengine mzee? So thank you for patience, for listening to the boss presentations, and also from Mr. Kibaden, witness as our champion in physical activities in the country. If anyone has a burning questions, we have only 15 minutes for this session, please. Ushers.
Thank you very much, all the presenters, for very wonderful and enlightening presentations. My first question goes to my friend, Dr. Omari Ubuguyu. You have talked about the system and the environment. My concern is we are seeing now an increasing trend of our young people who are having academic sessions from 7 a.m. to 10 p.m. And they're having classes, and reading. So my question is, in this national action plan, how are we linking the health and exercise with the other sectors so that our young generation actually have the time to exercise? So what is the linkage there? So that's to Dr. Buguyu. My second question goes to, again, my brother, Dr. Mashili. You've talked about a very important point of exercise prescription, which is quite interesting to me, particularly, because as you correctly put it in your cartoon, most of the clinicians watasema fanya mazoezi sana. Okay. Now my question is, do we have data, if you could share with us, do we have data on the exercise prescription vis-a-vis, let's say, one disease, somebody who has obesity or have hypertension or have, do we have data which shows if you do that, actually you have a better outcome? If you could share with us. Thank you.
Another question before we summing up.
Thank you. My name is Augustine Amando. I have a question. I like a suggestion to Dr. Mashili on the webinar MUHAS part, whereby he say that he will be monitoring a physical exercise to MUHAS faculty and students here at Mnoganzila. I have a suggestion because when I see the criteria which will be provided, like health, fitness, and profile assessment, exercise and physical activity prescription, and when you see the our daily activities, it's quite difficult for people to come here at MUHAS. How will it be good? Will it be much more good if we can have a digital application or digital app whereby people will be monitoring their physical exercise and fitness? I think it will be much more better than coming here every day. Thank you.
Yes, gentleman.
Yeah, thank you. I have a question for Dr. Mashili. Currently, there is a significant number of youth, of course, who are using like supplements, steroids and protein. So, can you talk more? Can you just talk a little bit on it, because there is much branding of from the companies, but most of them just are using the supplements without knowledge and just for muscle gain and whatever. So can you please talk about it?
Okay, thank you. I'm also having a question to Dr. Mashiri. I just wanted to ask, nowadays you see young people, we have a behavior of doing physical exercise just to generate muscles and whatever. So I just wanted to know, is it the correct part of physical exercise that can help our health, or is not a good thing to do for our health, especially on a physical exercise? Thank you.
Yeah, thank you very much, all the presenters. I think it has been very enlightening. Mine goes to Dr. Omari Buguyu. With the current trend of urbanization and the commercialization of everything, including the open spaces, what strategies do we have in place, you from the side of the government, to ensure that we have inclusive sportsmen in the active society, to all the children, including the poor and from the rich families? As at least now, those who are well off can pay for the open spaces and do exercises. But how do we bring inclusivity to these other disadvantaged groups coming from the government side, not from the researchers' perspective? Thank you.
Last two hands from the ladies.
Okay, thank you so much. My question goes to my teacher, Dr. Mashili. May I know, where do the two meet the resistance exercise and aerobic exercise in bringing health? And what are the detriments that a person can incur if they go to the levels of intense level of physical activity? I mean the advantages vis-a-vis the detriments. Thank you.
That one?
Yeah, thank you. I have two questions. One goes to Dr. Bugui. I want to know, because we have a little bit challenging current, especially the construction, especially for the lots. Most of the construction, they don't consider where the pedestrian will be going, and that will be very facilitating, enabling environment for the people to work, to do exercise. So it's like you are working in isolation. I want to know what are the considerations to make sure that even in the, when we are doing construction of the road, at least they consider whether these people be working on this road. The second goes to Dr. Mashiri. At this era of climate change, does your prescription exercise consider the issue of climate change?
Thank you. Can you respond first? And we'll see if our time allows for more questions or not. Should we start with the one with the most question? My boss, Dr. Buguyu.
Okay, thank you very much. I have three questions, and I think all of them fall into one category, active systems. And the only problem that we had initially was alignment of our plans. As I said earlier, when we did situation analysis for physical activities in Tanzania, we found out that there are 14 policies with legislation in it, and some they are contradicting one another, but their complementarity were very minimal, and very few policies which were aligned. Luckily, when we developed the action plans for physical activity in Tanzania, it was inclusive. We had more than 10 ministries in mainland Tanzania, and again with our counterparts in Zanzibar. So it is a United Republic of Tanzania who sit together establishing this physical activity guideline. Yet, we have not anchored it higher within our ministries. So in April this year, we had technical committee led by Permanent Secretary for Ministry of Health. The purpose was calling all permanent secretaries, taking them through the plans, and then we can co-create some of these initiatives. Specifically for schools, we were teasing out even ourselves what kind of the physical activity that we see it is fit within the current settings, because the environment has changed. Very dramatic changes within our setup. It is not easy nowadays to ask, even Professor Kija, even you yourself, you can't ask your child to travel anywhere beyond 1 kilometer because you are not sure of his or her safety. So it's difficult now to tell schools mchaka because we don't know what will happen. So what we are doing at the moment, in collaboration with WHO, International Olympic Committee, Earth Minister of Health, and other colleagues, Mashiri, their Physical Activity Association of Tanzania, TANCDA, we are together, and now we are creating community sports. And we use schools at least to get some demonstration as demonstration interventions as a pilot and demonstration site. Where should we anchor physical activities in youth? So from that, we could prescribe at least a guideline telling the schools and Ministry of Education that we could probably have these kind of physical activities in our setting. MUHAS is giving us an offer of at least having in-service training to teachers, at least to have a background on physical activity education so that it will be easy for them to guide. These children are different from our era, because once you train somebody's child and get problem, then you'll be in trouble. So we want to make sure that the environment is supportive enough. Once we put them on physical activity, then their safety is also guaranteed. But we are in aligned with the Minister of Education in this action plan, but we are not there yet. The second question was on rapid urbanization. Yes, we have a problem with the rapid urbanization, and there is a biggest problem on alignment between Ministers of Land and PURAJ, because the overall planner is the Minister of Land, but land distribution, planning, actual planning, utilization is under PURAJ, especially on the local government. So sometimes the Minister of Land has a very good plan, but the community change the entire plan, and most of this open space change the utilization by the resident of those areas. They set a meeting and they decide on the utilization of land. So with the current plan, with the interministerial technical working meeting, this is one of our proposals. Once we have a master plan and identify the recreational areas, we should abide to the master plan, because there are experts who had some calculation and see in the in the setup of 1,000 population, a size of open space will be measured based on the type of the residential development that they are planning. So that is in our plan. It is not yet executed. You may find out that today some of the open space are converted into market and other things, because we have not yet get a policy to prohibit utilization of those lands. But we are working with the other ministers. This goes along with the constructions. We don't have a strong policies to reinforce. Whenever we construct road, we should consider for walkways. But with the Healthy City initiative, we are promoting that. And there's places like Dar es Salaam, there are some areas that they dedicated to have Healthy City. I was talking to RCs of Dar es Salaam, and he was assuring me that you've seen in poster, there are some roads dedicated to have walkways, but it won't be all the roads, because it is expensive. For every kilometer that you construct the walkway, there are costs related to it. So there will be some dedicated roads which will be having those walkways. But the car-free days was the easiest and quick win. And actually, we were able to convince permanent Prime Minister to have that plan of car-free day. It is started in Dar es Salaam. We think that it goes in other regions as well. The point is, we want to promote safe physical activities along the road, and then probably it can come into the mind of many that we need to have access to those walkways. But for sure, this may not happen in our generation. All roads to have walkways, but some may have some consideration.
Dr. Mashiri?
Thank you. The first question from Dr. Kija, I think, was about exercise prescription and whether there's data backing exercise prescription. Yes, there is data. And a very famous campaign from the American College of Sports Medicine called Exercise is Medicine is very popular. Even South Africa applied that. And one of the things that they say is to have an exercise prescription written. And there are a lot of studies that have shown that it's quite effective when it is written, not just because it is written, because it is detailed. What type of exercise, how many times, what is the intensity? So it becomes easy when you get all those details. Now, the question is for us, we are not sure whether that is feasible. And some of the studies that we're trying to do here to see, but there's overwhelming evidence showing that physical activity prescription is quite effective, simply because when somebody see something is written, then they take it more serious. It's like, you know, when a medicine prescription is written. The second question was about a comment from a gentleman over there about where the MUHAS. That's Generation Z, right? So he talked about application. I think having an application is good, but one caution about application, I think it's good you raised that question and comment. There's nothing like everything fits all in this world. We're all different. And it's quite common for people to go into the internet, pick up programs, and then they start doing that. And the reason why we are talking about assessment and prescription is because it has to be individualized. We are different in terms of genetics, we are different in terms of what we eat, we are different in terms of the targets, we are different in terms of diseases that we have. The physiology is somehow different. So application, yes, it helps, but it does not replace like physical exercise, never. So I think what we can add is probably to also have the digital platform, but not to leave alone the physical presence. I think physical presence is quite important. And then another very good question about supplements for muscle gain and things like that. Yes, supplements are there. Supplement use is quite common. And supplements are good and bad, depending on what supplement. I use supplements sometimes. We have this tendency of hiding things, reading at night, people don't see you, and then you pass exams so that they get surprised. Sometimes you need supplements, especially when you're going for extreme training. There are certain supplements, even players like Ronaldo and all these players, they use those supplements. And some of the things that we're trying to explain to people is to understand what is called sports nutrition. An athlete is a different individual because they train, they're like super people. They go beyond the physiological, and there are certain things which need to be replaced. So there are supplements which are good, but there are supplements which are not good. And there's what we call doping, like steroids, obviously. These are some of the things that are not allowed in sports. And you've had someone being banned from participating in sport because they are doping. So there should be a difference between doping and supplement. There should be an understanding of supplements which are good and when do you need supplements. The thing is abusing supplement. You don't need supplement all the time. There are people who need supplement because they train extremely. Or for instance, if a football team is in a tournament, they have frequent matches and they need to recover. So there are supplements which can fasten recovery. So just to answer your question, supplements can be good, supplements can be bad, but that's why we're saying we need to have this kind of knowledge to understand which supplement, when, who, why. Those are the things that we need to understand. And then there was another question about resistance and aerobic. I didn't catch that question very well. Let me answer the second one, where she asked about the intensity of exercise and what can happen. Yes, if you overdo exercise, obviously, overuse of anything is harmful, but it is not very common. And I usually say some of the side effects that are claimed to be side effects of exercise are actually not side effects of exercise, rather side effect of performance enhancers, the supplements and stuff like that. And then people end up blaming exercise. But it is true when it is too intense, especially when the duration is over. If you extend the duration, that can be more dangerous because you start utilizing your muscles and things that you're not supposed to utilize because the body also has a limit. So there should be a certain intensity which is recommended. Again, the reason why we are saying that exercise sounds like something which is very simple, everybody knows it, but that's not true. Exercise, people need to have knowledge to be able to do the right type of exercise and the right intensity. And there was another question about muscle. Yes. Like training for muscles, is it good or bad? Depends, but it is good. Looking good is not bad. Looking good is also good because looking good is good for your mental health, right? So if you think muscles make you look good it's not bad, but obviously you are not going to overdo. It depends on what you want for. You're not going to compete for lifting, so you don't want to train to, you know, be like Schwarzenegger those days or something like that. You don't need that. But if you want to have muscle builds so that you can, you know, put on your shirt, looks good, it's not a problem at all. So looking good is also part of feeling good, feeling confident. And if you think building muscle in the right way is good, just go for it. It's not a problem. The issue is don't misuse supplements, don't dope, don't go for steroids, don't go for stuff that are not allowed because they will mess up with your health. For instance, we've had bodybuilders getting problem with the heart, and people will say because of lifting weight. No, it's not because of lifting weight, it's because of the drugs and supplements that they're actually using and not because of lifting weight. So again, going back to having the right knowledge, understanding the type of exercise, but also the duration and intensity for what you want to achieve according to your body type and your health profile assessment. Thank you. I think I've answered all. Or did I forget any?
Thank you.
I hope there's no question to Kibaden. Because you're my boss, so I have to get one more from you. Only one, I think, one question. So, hii ni swali la upendeleo. You'll have time for them later.
Hello. Yes, swali la upendeleo kwa King Kibaden. Una zaidi ya miaka 70 na umetoka hapo unakimbia vizuri sana. Unaweza ukatupa siri yako tu kwa kidogo tu kwamba wewe unafanyaga mazoezi toka zamani, toka huko unacheza Simba, unakuwa kocha wa Simba, unafanyaga mazoezi kwa wastani masaa mangapi labda kwa siku, na unafanya mazoezi gani sana hata sasa hivi ambapo umeshastaafu unafundisha vijana? Mazoezi ambayo unayafanya sasa hivi ni tofauti na zamani, lakini kwa sasa hivi unafanya mazoezi masaa mangapi na unafanya mazoezi gani, ili na sisi tujaribu kuiga, ili na mimi Mungu akinijalia nikifika umri wako niwe naweza kukimbia kama wewe.
Asante sana. Mimi nafanya mazoezi kwanza kila siku, kwa sababu nipo na timu ya vijana hata na wakubwa, lakini nimejiwekea tu nikipata masaa, au kwa mfano kiwanja kikubwa kama cha uwanja wa Taifa, ukikimbia mita 3200 zinatosha. Tena nakimbia mita 3200 kwa dakika 12. Kama unaweza kufanya kazi hiyo inapendeza sana. Alafu lingine, mazoezi ya viungo, kustretch viungo kuanzia shingo mpaka miguuni, lazima upate kila siku. Kwa maana hiyo ukiendelea hivyo huna tabu. Mimi naweza nikanyanyua mguu wangu mpaka naupeleka juu kwa hauna shida. Kwa kunyoosha, yani nimeshazoea miaka hiyo 75. Na lingine, kuepuka vitu ambavyo unaona si lazima kuvitumia. Kuepuka vitu ambavyo si lazima kuvitumia. Kwa mfano, mafuta yakizidi sana hayapendezi kula. Mimi nafunga kwa wiki mara 2. Mpaka leo miaka sio, kila wiki mara Jumatatu na Alhamisi nafunga. Pia kujizuia vitu vingine, kufunga ni sahihi kwa kutengeneza mwili wako. Usiusumbue bila sababu. Kama mahali pa kukimbia unaweza ukakimbia, kama kwa kutembea utatembea. Lakini usilazimishe masaa zaidi. Saa 4 unataka kulala wewe mpaka saa 8. Mwingine yuko kwenye simu ana chat tu. Utalala saa ngapi, utafanya shughuli saa ngapi? Kwa hiyo ni muhimu kwanza kutunza mwili. Vitu vya mafuta, vitu ambavyo unaona hivi sio sahihi, kuongezea sukari kizidi au chumvi kizidi ni tatizo.
Yes. Okay. Sorry, I forgot one question about climate change. Cross-cutting issues. He asked whether exercise prescription has considered climate change. I think it has, because part of prescribing exercise is telling people to participate in what we call active commuting, that is walking and cycling, meaning that not using motorized transport, which can damage the environment. But there are so many other things to do with cross-cutting and climate change. Thank you.
Another round of applause to our presenters. So before we close this session, I would like to introduce to you Mr. Waziri Ndonde, who is the president of Tanzania Physical Association and also a very good friend of ours and a physical trainer. Please stand up for people to see you. So after this session, we are going to open what we call Fitness Assessment and Human Performance Lab, Mabano Gym, right? Here at Mloganzila. So you're welcome to see it and also to learn some of the features. We will also take you through, explaining some of these instruments and machines that are inside there. So I think this is the time. We have only half an hour, and then we can come back for the closing session. Thank you again, and have a good day. Picha. Kwa hapa jamani. Tuna social media wengine hapa. Kamera. Okay. Kwenye gym jamani, tunataka kuona gym yetu. Fitness Assessment Lab.
Direction. Direction.
Please follow Ndonde, Mr. Ndonde. It's on the ground floor, isn't it? Which side? This side, eh? This side, please.
If you're a business owner, then animated explainer videos are the best way to capture attention. Get more.
How to get the most of Grammarly free. It's Kayla on behalf of Grammarly to tell you all about the
We are soon going to start our closing ceremony. So I kindly request everyone to take a position.
Nakupenda sana, mzuri sana, Elina wangu. Nakupenda sana, mzuri sana, Amazulu.
And we will take our positions so that we can start with the closing ceremony. I kindly request the Vice Chancellor, Deputy Vice Chancellor, I kindly request the Vice Chancellor, Deputy Vice Chancellor, Research and Consultants, the Acting Deputy Vice Chancellor, Academics, the Chairperson of the Organizing Committee, Dr. Omari Ubuguyu, representative from the Ministry of Health, Director of Research, Publication Innovations, and Chair of the Scientific Committee to come to the high table using my left-hand side steps. Vice Chancellor, Professor Apolinari Kamuhabwa, Acting Deputy Vice Chancellor, Research and Consultants, Professor Bruno Sunguya, Acting Deputy Vice Chancellor, Academics, Dr. Dorini Kamori, Chair of the Organizing Committee, Professor Raphael Sangeda, Director for Research and Innovations, Publication Innovations, Dr. Nahia Salim, representative from the Ministry of Health, Dr. Omari Buguyu, and Chair of the Scientific Committee, Dr. Edward Kija, members of the MUHAS community, researchers, scientists, students community, ladies and gentlemen, good evening. Welcome to our closing ceremony of the 12th MUHAS Scientific Conference this day of 28th of June 2024. My role this evening is just to invite the chair of the organizing committee who will highlight the major recommendations from the vibrations of the scientific presentations since day one to this evening. And then we'll invite our guest of honor this evening, who is our very own Vice Chancellor, Professor Narika Muhabwa, to start by giving awards to selected recognized people for this particular event, and later on for the closing speech. Professor Raphael Sangeda, you are most welcome.
Thank you very much, MC. Guest of honor, and all the leaders who are sitting on the high table. It's a great honor to stand here this time to conclude what we just started yesterday, which I can say is a very, very successful meeting. First of all, I want to start by thanking you, guest of honor, Professor Narika Muhabwa, for sparing your time to be with us throughout this conference and until this time when we are closing the conference. I also want to thank our dear participants for also coming very far and near to come to this conference and making it one of the very, very successful conference. Thank you very much, and give yourself an applause. We are very thankful to all the chairs, all the rapporteurs, and all the ushers, and all the people who worked very closely to make this meeting successful. Thank you very much. So I will start with, to show you how successful this meeting was, I will start with give you the number or a picture of the number of participants who have registered and attended this meeting. And you can appreciate that was indeed successful because we have registered a total of 631 participants. Please clap for yourself. Of course, it's a MUHAS conference, and we had 443 MUHAS participants. But we also had quite a number of non-MUHAS participants, up to about 88 participants. These participants came from a number of institutions in Tanzania and in abroad. We had foreign participants from 4 countries, including Japan, China, Ecuador, United States of America. And for the local institutions, I will not mention all of them. There are many, but we can appreciate the presence of MNH, JKCI, ORCI, SUSA, Zanzibar, Ministry of Health. I will appreciate the presence, of course, for the foreign institutions, Hiroshima University and Melody International Limited in Japan, but also the other institutions from Tanzania that attended. So that's how successful our meeting was. Now, with regard to the scientific, we have had so many posters as announced yesterday. About 178 abstracts were submitted. And out of these, 8 were posters, and the remaining were presented as oral presentations. So again, that was very successful, and congratulations to all the presenters. We have scooped some of the highlights from the presentations. We will not mention all of them, so forgive me if there was a very burning issue that you presented and I'm not going to say it, but of course, feel free to mention it through our email, and the final recommendations will be on our website. And of course, as you heard, the Katibu Mkuu asked that we send those recommendations to our office as well. So the key highlights were: 1, there is limited utilization of meteorological data in Tanzania, which can be used to predict patterns of climate change and its effect or its relation with the health. So this is something that we need to work on. On the second highlight, we see that there are a number of patients who are admitted in ICU, and there's an increased risk of developing exposure keratopathy. We see that there is also reduced of visual acuity among primary school students, which affects their overall academic performance. We have also noted that there is limited access to assisted reproductive technologies for the management of infertility. We also noted that nearly half of critically ill patients with sepsis admitted at MNH died. So this is something that needs to be worked upon. We have also noted that male partners to cervical cancer patients suffer from other non-disease challenges which affect their quality of life. We see that despite of advancement in technology, we need to strengthen basic components to improve patient care in general wards and reduce the number of patients being sent to the ICU. We have also noted the prevalence of skin lightening products, that this has become more among the front desk workers, and they suffer the most of the skin lesions. We have also heard that simple eye examinations is not a normal performed test by most of healthcare workers, meaning that this is something we should work upon. We have also heard that pre-exposure prophylaxis, PrEP, its use among female sex workers is rare, and perhaps this is something that we should work upon. So in addition, we have witnessed the launch of the health laboratory, and we have been invited by the experts to make use of it. And other than this, we have heard a lot from the speakers, and we hope that this can be brought to implementation. So now, so these were our comments, and as I said, some of them will be in our main report, and they'll be presented to you on our website, which you all have access to. So other than that, I want to thank you all, and the guest of honor, I will request you, before you give your speech, will be presenting the awards for best oral presentation and posters, which will be presented by the chair of the scientific subcommittee, which will be presented in terms of what kind of awards are. And then we'll be pleased to invite you to come forward to present those gifts, and then you can give your closing remark, and that should make the end of our conference. Thank you very much, and I hope to see you in the coming years. Thank you.
Thank you very much, Chair, and thank you very much, the Vice Chancellor, Professor Polinarika Muhabwa, Professor Bruno Sunguya, the Deputy Vice Chancellor, Research and Consultancy, Dr. Doreen Kamori, the Acting Deputy Vice Chancellor, Academics, Dr. Omari Bugulu, who is representing the Ministry of Health, and Dr. Nahia Salim, the Director of Research and Publication. My task right now is to name the winners. And before I name them, may I kindly request the Vice Chancellor and the Deputy Vice Chancellors to please come down so that you can present the awards to our winners for this 12th MUHAS Scientific Conference. This year, as the chair of the scientific committee, I've mentioned we have a very successful conference at Mloganzila. The first time this MUHAS conference has been held at Mloganzila. So this year we have two winners, and these winners have been based on the abstracts that were submitted and reviewed by the scientific subcommittee and scored, and these are the ones that received the highest score in each in the oral presentation as well as the poster. So the first winner, in recognition of an overall abstract under oral presentation, the winner is Emmanuel Gibe. Thank you very much. The second awardee is for the best abstract, which was presented in the poster sessions. And the winner for this award is Jacqueline Kiwele. Jacqueline Kiwele, she's not here. If she's not here, can we have a representative? I believe she's from the internal medicine. Yes, we have a representative who will receive the award on her behalf. Thank you very much. So that marks the end of the awards for this closing ceremony. And now I'll hand over the mic to MC, to the chair, to welcome the Vice Chancellor for closing. Thank you.
Yeah. So thank you, guest of honor, VC Professor Polinarika Muhabwa. So I can now invite you to officially close our conference.
the Deputy Vice Chancellors, research consultants, DVC academic, Dr. Obuguyu, representing the Ministry of Health, the chair of the 12th MUHAS Scientific Conference, the chair of the scientific committee, the organizing committee of the conference, researchers, MUHAS faculty, our invited guests, students, most of all mzee wetu, mzee Kibadeni, karibu sana. Good afternoon. So let me join others, first of all, to give appreciation for those who have made this conference a success. And I will start by extending our appreciation to the guest of honor, the Permanent Secretary in the Ministry of Education, who opened the first session yesterday. We do acknowledge their presence. We also register our appreciation to the MUHAS Council Chairman, who was here yesterday. Our first MUHAS Vice Chancellor, Professor Paranjo, was here. But also yesterday, we had a representative from Ministry of Health, our partner institutions, and other organizations that attended yesterday. So this is the 12th MUHAS Scientific Conference. So it's a series of conferences that we have been conducting annually, consecutively. And let me say, this conference has been a success, I think, because it was very much organized and because it was the first time that we conducted this conference in Mloganzila. So I think this is the historical milestone that we had our first conference at Mloganzila. This is will be our main campus. It's because of the size and because of the planned facilities that will be established at this campus. So I think we need all to be happy and be proud that we had our 12th conference organized at our main campus. Also, let me thank people who have made this conference success. We had the keynote speakers. We had scientists who led satellite sessions, chairpersons in the repertoire of the sessions. But for those who shared the research findings through oral abstract presentation, as well as presentations through posters. But also, we need to thank our service providers for different services of this conference. And the feedback that I received today, many people have commented that we had the best service provider for meals. That the food was very delicious and it was well arranged. It was appetizing. So we thank the caterer for the good service that we are well fed, and that's why probably we could concentrate in this conference. Let me also thank and congratulate our award winners, the two winners that we have presented the trophies today. And incidentally, they are both students. These are our residents from the Department of Obstetrics and Gynecology and from the Department of Internal Medicine. So we congratulate our students. So the students have been winners above their teachers. But also yesterday, we had two awardees. Professor Anna Kess, she was awarded and recognized for outstanding contribution in organizing MUHAS conferences. But yesterday also, we did recognize the first MUHAS Vice Chancellor, Professor Paranjo, for his leadership that led to acquisition of Mloganzila land. And yesterday evening, I received a feedback of Professor Paranjo, and he's very, very much thankful. And he says he will always be available to support MUHAS. Ladies and gentlemen, I'm certain that during these 2 days, you have significantly increased your knowledge. If you look at the number of presentation, the type of presentation, at least for some few that I was able to attend, they were very much interesting. They are very much interesting. So I believe we all have increased knowledge, some competencies, and that will eventually change the way we practice, whether we teach, we conduct research, or we provide a service. As I said, MUHAS has been conducting this annual scientific conference. Now it's for the past 12 years. And the purpose is to showcase the research activities that are conducted at the university in collaboration with our collaborators. And these events, like the conference we had yesterday and today, are meant to provide a platform for researchers and other stakeholders in the higher education sector, in the health sector, within and outside Tanzania, to disseminate our research activities. And this is the time and this is the venue when we have been conducting research, you have a very interesting result. It is very good that you come and share your findings. People will ask questions, people will need clarification. And I think as researchers, that's what we need. We need to do research, disseminate, and get feedback from the stakeholders and to inform us of what we are doing and improve on what we are doing. So I would like to commend efforts made towards achieving this objective. And I want to urge all researchers to continue taking the lead in search and dissemination in Tanzania and abroad. As we saw from yesterday, the theme of this conference was Science as a Story of Life, the power of research, innovation, and collaboration in improving resilience health system. And as you can see, the theme was specifically chosen due to the epidemiological transition of our country as we are seeing today. So this is evidenced by the heightening of non-communicable diseases. As we are aware, we have been conducting also regional and national non-communicable disease annual scientific conference. We see changes in the epidemiology of these diseases. And the center that we have just inaugurated is a testimony that we are very serious in combating non-communicable disease, including cardiovascular diseases. So I therefore believe that the solutions that we have made in this symposium will be shared to the relevant stakeholders and importantly to those people who make decisions, the policymakers, so that the findings, the recommendations that we have will bring impact. I trust, as we have been doing over the years, that we will make these recommendations and most importantly, develop the policy briefs in a language that our colleagues in the decision-making office will understand and implement our recommendations. I also believe that students and the other delegates have learned from experts, from each other. And most importantly, I trust you have networked. When you come to a conference like this, it's not only the presentation, the knowledge that you share, but also you network. I believe among ourselves, we have networked and we have found friends and colleagues, and we have found potential collaborators, mentors, or supervisors. And also, as was presented yesterday, I think you may have developed a passion. I believe you have developed passion in conducting research and also dissemination. But I believe also through the presentation that we had, I'm sure you have come up with 1 or 2 research ideas. And probably next week, over this weekend, you will start writing something with ideas that you may have acquired through this presentation. And that's the reason why we meet. And this is the platform that we use to meet and get research ideas. And I believe also for students who have presented the results, the findings that may be part of the dissertations or thesis, I think you already have the answers for some of the questions that will be asked during your Viva Voice. So I believe this conference will leave you inspired to conduct further research and to address the key health challenges that are facing our communities. As I conclude my remarks, may I take this opportunity once again to thank the keynote speakers, the presenters, you conference participants, wonderful session chairs, and what I noted this time, that most, if not all, of the sessions were started on time and they were concluded on time. And I think this is one of the attributes of researchers, that we care about time. But also, we think the repertoires, and I believe through the work that we have done, we shall be able to get a report that will draw recommendations, including also the policy brief that we will compile. But most importantly, the conference organizers. The organizers had a sleepless night. I think Professor Sangeda and his colleague, I think they spent 2 nights here. I don't know if they had mattresses, but they did spend the nights here. And I think this was because to make sure that the conference is well organized and is a success. And we are very proud of you, Professor Sangeda, and your committee. But also, we need to acknowledge the work that has been done through the Office of Deputy Vice Chancellor responsible for research and the Directors of Research, because the organization and the preparation is certain. Thank you very much, Prof. So we encourage your team through your office and the Director of Research and your team to continue soliciting ideas. I believe your team also had done in networking. I think also we need to learn how best you can improve further these conferences. So as we prepare for the next conference, let's start here to make sure that we take good ideas and suggestions that we received. So as we conclude this conference, I wish all the delegates who have come from near and far, as was mentioned by the chairman of the organizing committee, we had delegates from foreign countries and also from Tanzania. So for those who came from outside Dar es Salaam, outside Tanzania, let me wish you a pleasant, safe travel back home. Our greetings and gratitude to your fellow scientists back home, and appreciation to your employers and leaders who provided permission for you to come and join us. And also we request that you provide the feedback to us and advise on how best we can improve such disseminations. So as I conclude my remark, once again, let me say this conference was a success, and it was a success because of your active participation. So it is now, as we close this 12th MUHAS Scientific Conference, I also take this opportunity to welcome you to the 13th MUHAS Scientific Conference, which probably will take place in June in 2025, which is next year. So, ladies and gentlemen, it is now my pleasure to declare that the MUHAS 12th Annual Scientific Conference is officially closed. Asanteni sana.
Thank you very much, the Vice Chancellor, for officially closing the ceremony with those protocols observed. We are going to have only one photo for the organizing committee as a symbolic key for the closure of this event and for the interest of time. I kindly request all members of the organizing committee to march forward. Na kwa heshima ya pekee kabisa naomba nimkaribishe pia mzee Kibaden Dala Mputa ajiunge kwenye hii picha. Karibuni organizing committee for the group photo.